Should I share my screen?
So you need to first, I'll introduce Dr. Mani and then we can begin.
Just a second, sir. I'll introduce you and
Ma'am,
then
please start in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all on the second day of Oncology Update. With immense pleasure, I would like to welcome and invite Dr. Manish Sharma, who is consultant and head of Unit Medical Oncology, Rajiv Gandhi Institute, Delhi, for the further proceedings. Over to you, sir.
good evening all. Thank you so much for being here, and thank you my colleagues, my friends, and all the students who have joined on this evening. And in continuation, the day 2 of our CME, we will be discussing on the lung cancer. So today, the discussion is about lung cancer. Yesterday, we discussed about breast and ovarian cancer. So in the next 2 hours or so, we'll be discussing about uncommon mutations in non-small cell lung cancer by Dr. Sudeep Das. Second session would be on neoadjuvant immunotherapy. I think that would be a very interesting talk by Dr. Rushabh. Then we will be discussing about extensive stage small cell and lung cancer, then atezolizumab in first line lung cancer, followed by panel discussion, which will be moderated by Dr. Chaturbhuj Agarwal. He is international faculty for the year. So coming on to the first session, uncommon mutations or compound EGFR mutations, they are highly heterogeneous subgroup, and we have started finding these mutations nowadays because we are just diving deep into the tumor. We are doing deep sequences with the help of NGS being available over next door. We are able to find out uncommon mutations. We are having compound mutations. So let us see what Dr. Sudeep has to say about uncommon mutations in NSCLC. Dr. Sudeep Das is consultant in medical oncology and hematology in Medica Super Specialty Hospital, Kolkata. So in next 15 minutes or so, he will be discussing on uncommon mutations. Is it correct to rely on TKI alone? I welcome you, Dr. Sudeep.
Yeah, thank
Good evening,
you, sir.
sir.
Thank you, sir. Thank you for your kind introduction.
Please go ahead and share your screen, sir.
Yes. Thank you, Dr. Manish Sharma, sir, for giving me this opportunity, and thank you to all the organizers and CRSF. So I guess my slides are visible, right?
Yes, sir. So you're audible and slides are also visible.
Yes,
sir. Please.
We are actually witnessing landmark changes in the management of advanced lung cancer, and we have moved on from reflex genetic testing, which we were doing 1 decade earlier, first testing EGFR, then if it is negative, looking for help, then moving to ROS or MET. So now we have moved on from reflex genetic testing to upfront, comprehensive genetic profiling by NGS, as correctly mentioned by sir. So my talk will be uncommon mutations in non-small cell lung cancer. Is it correct to rely on TKI? Now, what are the options we have except TKI? We have palliative chemotherapy. We have immune checkpoint inhibitors. We all know that the platinum-based doublet chemotherapy gives the historical the PFS was not that great. It was 4 to 5 months only, and the median OS was hardly 10 to 12 months only. So let's see how TKIs are doing in these uncommon mutations. Now, first of all, we need to understand that though these uncommon mutations, they are not so common, they are 1 to 2%, but together they form a substantial number of, patients of non-small cell lung cancer. And most of these uncommon mutations, they are actually poor prognostic factor. They are not a very good responder to chemotherapy as well as immunotherapy. So let's find what is the data. Now we know that exon 19 deletion and exon 21 L858R are the common EGFR mutations, and in uncommon EGFR mutations, probably afatinib do better than any first line TKI. And irrespective of mutations, we all know that osimertinib should be the first choice. Now there are some uncommon EGFR mutations like exon 20 insertion, which is a center of interest these days. So exon 20 mutation, they are not good candidate for conventional TKI, and when they were tried to expose with chemotherapy and bevacizumab, the outcome was not that great. Only
Your slide is not moving.
okay. Now,
Yes,
now
sir.
okay. So you
Yes,
know,
sir, please put up in full screen mode, sir.
pardon.
Full screen mode, sir. Your slides were not moving. Full screen.
Now it's moving. Moving.
No, sir.
So whenever I am making it full screen, they are not moving. If I zoom out from full screen, then they are moving. I guess.
Yes, it is moving now. Yes,
Okay,
it is okay. It's
So
okay.
I was trying to say that there are some uncommon mutation which are exon 18, G719X, or exon 21L861Q, where if afatinib does better compared to other first line TKI. And another unique mutation is exon 20 insertion, which is also constitutes of 5 to 10%. They don't do better with TKI, and the chemotherapy plus bevacizumab was tried, but there was a modest improvement of PFS. See the PFS with chemotherapy plus bevacizumab, median PFS was only 7.5 months. It is not, we are not happy to get that. So immune checkpoint inhibitors were tried, and even with immune checkpoint inhibitors, the median time to next treatment was also very dismal. It was only 3.7 months in EGFR exon 20 insertions. So that's how the role of newer TKIs came in place. First, the one strategy was to double the dose of osimertinib, that is 160 mg daily. See the diagrams. It shows that most of the patients, they had partial response at least or stable disease. In Zenith 20 trial tested the role of osimertinib in such situation, and here in median PFS was only 5.5 months. But finally, there was some improvement with mobocertinib with a overall survival of 24 months and median time to duration of response with 17 months, more than 1 year. And we all know the impressive data of phase 1 Chrysalis trial with amivantamab, which showed that the median PFS was 8.3 months in such a bad prognostic disease, and a median OS close to 1 year, 22.8 months. Now coming to other uncommon mutations, probably we are all convinced that for treating ALK rearranged tumors, different TKIs are available, and we have moved from the first generation TKI crizotinib to second generation like alectinib or ceritinib, or even brigatinib and lorlatinib are also approved to be used in first line setting. And there's impressive almost doubling of the PFS when we use this newer generation of TKI. However, though the OS was not significant all the time, and it is because of the crossover allowed in the trials. So And these newer generation TKIs, ALK inhibitors, they have very excellent CNS penetration and CNS control rate. Now coming to another uncommon mutation, which is ROS1 rearranged. Now profile 1001 was tested for crizotinib in ALK rearranged, but this trial has an expansion, and in that expansion, 53 ROS1 positive patients were enrolled, and they were treated with crizotinib. Look at the objective response rate; it is very impressive, 70%, with a median duration of response of 17 months and median PFS of 19 months. So even the NCCN also approves the use of crizotinib and entrectinib in the first line setting in ROS1 rearranged non-small cell lung cancer. Coming to another uncommon mutation, which is MET exon 14 skip mutation. We all know that capmatinib and tepotinib, these two TKIs are actually available, though different type 1 or type 2 TKIs are available, but these are the two drugs which are available. And see the median PFS with capmatinib in treatment naive MET exon 14 skip mutations. The median PFS was 12 months. Please remember, these are the patients who are actually the prognostically very unfavorable group of patients. They are not like EGFR mutated patients. And tepotinib had a median PFS in first line setting 8.5 months. And see that they have some response in even in second line setting also. So these are the different investigational TKIs which are in investigation in different phases in MET altered non-small cell lung cancer. Now coming to another uncommon mutation, which is BRAF mutation positive. We all know that single agent vemurafenib or dabrafenib was not good enough because of the downstream signaling pathway resistance mechanism. So in BRF 113928 trial in cohort B, when both the dabrafenib and actually trametinib, both these combinations were used, the median PFS was 8.6 months, which is not bad as far as the historical cohort of chemotherapy, the PFS we achieve with chemotherapy, which is close to 4 to 6 months only. So this is the updated OS with dabrafenib plus trametinib in second line, and the median OS was 18 months, not bad. And now another uncommon mutations, that is RET receptor tyrosine kinase, for RET fusions in non-small cell lung cancer. We all know that selpercatinib and tralcetinib, these are the two approved drugs. Now selpercatinib had a median PFS of 22 months in treatment naive. See the response, overall response rate was as high as 84%, which is close to the response rate we see with geftinib and allotinib in EGFR mutated patients. The pralsetinib also had an overall response rate of 70%, with the median PFS of 9.1 months in treatment naive patients. So they both the drugs got FDA approval. Now coming to NTRK gene fusions. So NTRK gene fusions in NTRK inhibitors, entrectinib and larotrectinib, these are the two drugs, and with the median PFS as 13 months or 28, even 28 months. So with the overall response rate as high as 64 to 73%. So we are quite happy with these TKIs. And now coming to HER2 mutations, we see two kind of HER2 dysregulation in lung cancer, either HER2 mutations or HER2 amplifications. The strategies are either you use a antibody drug conjugate like trastuzumab emtansine or trastuzumab deruxtecan, or you use a bispecific antibodies. Now Now, this is the data of TDM1, which showed that most of the patient in the series, they had either partial response or stable disease. And this is the actually Destiny Lung 01 study design, where there were two cohorts, HER2 overexpressed or HER2 mutated. And in both the actually cohort, trastuzumab deruxtecan had good efficacy, showing most of the tumors showing tumor shrinkage. And these are the PFS and OS curve. The median PFS with deruxtecan was 8.2 months, with a median OS of 17.8 months. So I repeat, these are the patients who are prognostically poor group of patients, and still, if we can achieve a median OS of 17.8 months, that is quite impressive. But please remember, both the setting, the drugs were the HER2 directed drugs were actually used in second line setting. So this was a summary and key takeaways from Destiny Lung 01 trial. And so this is the actually the diagram showing that the use of HER2 directed therapy in second line setting. Now, so by this time, we all are, I think we all are convinced that these multiple TKIs, they do better than conventional chemotherapy. And though it's a very complex scenario, it's not like that the patient only can harbor only single mutation. Only deep sequencing NGS can tell you that there can be complex mutation status, and which can also guide your therapeutic therapeutic choice. What about applying immunotherapy in such uncommon mutations? So this was a data of very robust data of 500, more than 550 patients who had driver mutation, who had driver mutation positive lung cancer. And the result from the immunotarget registry showed that the role of immunotherapy in this driver mutation positive lung cancer showed most of the time in driver mutation positive lung cancer, immunotherapy had the efficacy is questionable. Most of the partial response rate was as low as 10 to 15% only, except there were two exceptions, which were KRAS mutation and one was BRAF mutation. These are the two driver mutations which had some modest activity of immunotherapy. In other driver mutation for cases, the role of immunotherapy was clinically not meaningful. So, to summarize, this is a very beautiful slide in which actually they tabulated the approved drugs for uncommon mutations. This will be my last slide. In EGFR exon 20 insertion, amivantamab or mobocertinib, ROS1, crizotinib or entrectinib. For rate rearrangement, we have selpercatinib or pralsetinib, NTRK fusion, larotrectinib or entrectinib, BRAF V600E only, not in other BRAF mutations, dabrafenib and trametinib, made exon 14 skip mutations, capmatinib and tepotinib. And very interestingly, now we are having sotorasib also in KRAS G12C mutation. So to summarize, we have made great strides for patients with uncommon mutations. Multiple potential targetable mutations makes it more difficult to keep it all straight, because we all know that complex mutations, they do exist. So we'll continue to see new and better treatment emerging for these and other targetable mutations in future. So with this, I thank you all for listening me patiently. Thank you.
Dr. Sudeep, thank you for such a wonderful presentation. You almost covered all the aspects of uncommon mutations. So if there are any questions, we can take few questions. So one of my questions, Dr. Sudeep, so you have started doing NGS for all your patients, or you are doing sequentially for first EGFR, cross-met, and then followed by NGS? Because these all uncommon mutations we tend to find only when we deeply dive into the genomes of the tumor. So, are you doing NGS for all of your patients?
Sir, we have stopped doing reflex testing. First of all, our pathologists give information about ALK and PDL1 from IHC, and in most of the patients we use the coupon which is available for at least 12 gene lung panel, limited lung panel. There are some patients, 10% patients who have access, they go for broad lung panel. But in most of the time, we are doing at least a limited lung panel. But it is for sure that we have stopped reflex testing one after another.
Okay, so what we are doing in our institute, so once we order NGS, we find that at least 3 weeks times are needed. So for all our patients, we will do EGFR, cross-met, and reflexly the samples would be sent for NGS also. So in our institute, we get these reports within 5 to 7 days time. And then if the reports are negative, we start the patient on chemotherapy and wait for NGS. Or otherwise, if the reports are positive, we start with the available results, because the turnaround time is, I think, very important. So your experience with a few uncommon mutation, can you share any? So complex mutation, uncommon EGFR mutation, can you shed some light on that?
Yeah, I have two patients. One is actually on capmatinib, which was exon 14 skip mutation positive. Is doing well in capmatinib, and unfortunately, the capmatinib patient assistance program got over. He was not progressing on capmatinib, but I had to put him on chemotherapy once the free drug coverage that program was over. Another patient who is receiving tepotinib is actually primarily was a EGFR mutation positive patient, and then as a resistance he developed exon 14 skip mutation. So we are treating him with a osimertinib plus tepotinib combination.
So that is, I think it is very true. So once we are doing NGS for all our patients, we can directly look into the heterogeneity of the tumor. And I share one of my experience with this NGS. And upfront, we had a patient who had EGFR exon 19 mutation in exon 19 plus MET also. So this being a poor prognostic sign, we asked for capmatinib as a compassionate usage. We started this patient on osimertinib plus capmatinib upfront, although we know that we don't have the approval for the same, but I can tell you that this patient is still doing fine with us, and this is post 7 months down the line. So I think NGS has a great role to play. And Dr. Sudeep, you did your job really well. Thank you so much. We will invite our next speaker.
Thank you, sir.
Thank you. So our next speaker is Dr. Rushabh Kothari. Dr. Rushabh Kothari is consultant medical oncologist in CanCure Cancer Center, Narayana Super Specialty Hospital, Ahmedabad. So we all know that we have the role of immunotherapeutic drugs in advanced metastatic setting in lung cancer. There are few trials in neoadjuvant setting, there are few trials in the adjuvant setting, but this space is still not completely filled. We still have plenty of questions regarding dosing, scheduling of the drug, neoadjuvant treatment. What are the complications that we can see during surgery? What are the advantages? What are the disadvantages? So for this, we have Dr. Rushabh Kothari. He is co-director, Oncology Cancer Center. He will be speaking on neoadjuvant IO therapy in early lung cancer. Dr. Rushabh Kothari, please.
Thank you for invite. I will walk through the neoadjuvant, especially the two trials, Checkmate 816 and Nadim trial. And will have a brief word regarding adjuvant treatment. Next slide, please. So, for the background, next slide,
Sir,
please.
you can access your remote control.
Okay. I'm not able to move. Okay, thank you. So, the background is that even in stage one, and as we move on from stage one to stage two and stage three, in spite of surgery, we have high local and distant relapse, and the majority it is distant failure rather than local failure. Most of the failure occur within 2 years, and with available perioperative chemotherapy, we can improve survival by 5 to 8%. So we can see that 5 year survival for stage two is around 50%, and for stage three it is around 25% with surgery alone. So we definitely require something more on it. We added chemotherapy. We could improve survival by 5 to 8%, but not beyond that. So we always needed something more than chemotherapy alone. Next slide, please. So I will first go through checkmate trial. Uh, can you help in changing the slides? I'm not able to do it. So checkmate trial, it was newly diagnosed resectable stage 1B more than 4 centimeter, 2 stage 3A NSCLC patient, performance status 0 to 1, no EGFR and ALK mutation. They were stratified based on stage 1B2 versus 3A, based on PDL1 status less than 1% versus more than equal to 1%, and male and female were stratified. 1:1 randomization to Nivo 360 milligram every 3 weeks with chemotherapy versus chemotherapy alone. Radiological staging after 3 cycles, and surgery was done within 6 weeks of completion of third cycle. Adjuvant chemo and radiation were optional, and then patient were followed up. Primary endpoint was PET-CR and event-free survival. The secondary endpoints were major pathological response, overall survival, time to death, or distant metastasis. And exploratory analysis was EFS by PET-CR status. Next slide, please. So the baseline characteristics in both the arm, Nivo plus chemo versus chemo, was similar. We have a good number of elderly patient more than 65 years of age. Performance status 1 patients around 31%, stage 3A patients around 60%, squamous and non-squamous again around 50% in each arm. So again, as per PDL1 status, more than 50% was around 20 to 25%, 1 to 49% was around 28% in Nivo chemo and 26% in chemo arm, and less than 1% was 7 patients in either percentage in either of the arm. Next slide, please. So in the Nivo chemo arm, around 83% of the patient, 149 out of 176 patient who received treatment underwent surgery, and in chemo alone arm, 75% underwent surgery. And post surgery, around 3% patient have received chemo or radiation, chemo and radiation. 5% have received radiation alone, and 12% patient have received chemo alone in Nivo chemo arm, and 22% have received chemo alone in chemo arm. So around 94% of patients completed neoadjuvant treatment in Nivo chemo arm and 85% in chemo alone arm. Next slide, please. So two important point: the surgical rate was not decreased by adding nivolumab, rather it was bit better numerically. Second important point, pathological complete response was 24% with Nivo plus chemo versus 2% with chemo. So based on these two data, we all were already excited about neoadjuvant immunotherapy. Then we have event-free survival data. Now this data at median follow-up of around 21 months we have median EFS of 31.6 versus 20.8 months with hazard ratio of 0.63, a very significant p-value, and confidence interval not crossing unity. At 2 years, 64% versus 45% of the patients are without progression or death. Next slide, please. So once we know that we have benefit in event-free survival, so in all the subgroup analysis, there are some subgroups which are important to see. If we compare stage 1B, stage 2 versus stage 3A, the benefit looks more in stage 3A. Stage 1B2, the line is confidence interval line is crossing unity. Again, when we see PDL1 status more than equal to 50%, beyond doubt it is benefiting with addition of Nivo, as we see in metastatic setting also. 1 to 49% patients, the confidence interval line is just crossing unity. Less than 1% patient, it is much closer to unity. So when we are considering giving treatment, especially patient has borderline finances, then this subgroup analysis is something which we can consider in selecting the patient. Next slide, please. So as I told, based on subgroup analysis, also here we can see that based on baseline stages, in stage 3A, the hazard ratio is 0.54, not crossing unity, with median EFS of 31.6 months versus 15.7 months. While in stage 1B and stage 2, hazard ratio is 0.87 and confidence interval is crossing unity. And the Kaplan-Meier curve, the separation is not as good as what we see in stage 3A. Next slide, please. For PDL1 expression less than 1% and more than 1%, again, for patients with more than equal to 1%, hazard ratio is 0.41, while for less than 1%, it is 0.85, and the confidence interval is crossing unity. So the quantum of benefit in more than equal to 1% looks clearly significant compared to less than 1%. Next slide, please. And when we compare it between 1 to 49% versus more than equal to 50%, the obvious benefit is maximum with more than equal to 50%, where hazard ratio is 0.24. And at 2 years, you see 85% without progression or death in stage 2, 3A and 1B patient, which is commendable. While that quantum of benefit is not clearly seen in stage in PDL1 1 to 49% of the patient, still the hazard ratio is 0.58. Confidence interval is just crossing unity. Next slide, please. So squamous and non-squamous both derives benefit, but the quantum of benefit looks more in non-squamous patients. Based on hazard ratio and confidence interval, we can see that, and even the separation in Kaplan-Meier curve is evident. Next slide, please. So one more finding which we see in many neoadjuvant treatment and even in many immunotherapy, that patient who achieved PET-CR, the prognosis of that patient is much better than the patients who have not achieved PET-CR. So this is the clear-cut separation between patients who achieved PET-CR and not achieved PET-CR. The median event-free survival was not reached in PET-CR patient, and the hazard ratio was 0.13, which is really significant. Next slide, please. Overall survival is still not mature, but there is early separation. We are still not in a condition to comment on it, but this is something which been. Next slide, please. So once we have efficacy, the next important thing is what are the adverse events. So based on the previous slide, we can see that adverse event looks similar in both the arms. There is no increase in toxicity or inability to do surgery by adding immunotherapy. So in summary, for Checkmate 816, addition of nivolumab, there is clinically meaningful improvement in event-free survival. The preliminary OS seems to be trending towards Nivo plus chemo, but still it is immature. Event-free survival in patients who achieved PET-CR is much better than and looks like an early indicator for therapeutic benefit of Nivo plus chemo. Safety profile is consistent with previous studies, the phase 1 and phase 2 studies in neoadjuvant setting, and it is not deterrent to surgery. So that is also something which we need to keep in mind. So Checkmate 816 is first phase 3 study with neoadjuvant immunotherapy based combination, which have shown improvement in EFS and PET-CR, and we are awaiting overall survival result. Next slide, please. So Nadim 2 is a similar study where nivolumab plus pegcilcarbo was given, and a control arm was pegcilcarbo. The patients in this study were only stage 3 and stage 3B. It is a phase 2 study, and adjuvant nivolumab for 6 months was allowed in this study after surgery. So there is some difference in design between these two studies. Next slide, please. So again, only 4 patients out of 57 were not able to undergo surgery in nivo plus chemo arm, while 9 patients out of 29 were not able to undergo surgery in chemotherapy. Next slide, please. The baseline characteristics were well matched in both the study group. Next slide, please. The patients undergoing definitive surgery was 93% versus 69% with nivo plus chemo versus chemo arm. Next slide, please. The PET-CR rate was 36.8% versus 6.9% in intention to treat population. Significant leap in PET-CR rate. Next slide, please. Major pathological response was seen in 52.6% versus 13.8%. Again, a major benefit. Next slide, please. Overall response rate was 75.4% versus 48.2%. Next slide, please. Adverse event, there was some increase in adverse event from 10.3% to 25% by addition of nivolumab, but the number of surgeries were not low. So there is some increase in toxicity in this group of patients, but we are able to do surgery and we are able to get a good pathological response or PET-CR rates. Next slide, please. So if you compare the toxicities, the grade 3 and grade 4 toxicities were a bit more in nivolumab arm. But if you go through the toxicity, it was fatigue, which was more. There was more febrile neutropenia, the grade 4 toxicities, and some transaminitis, which was more. So maybe that is something which we can manage or which is temporary. Next slide, please. So Nadim 2 is something like a confirmatory trial, which we got a hint from Checkmate 816. And we know that addition of nivolumab even in stage 3A, 3B patient improves PET-CR rate, improves major pathological response, and has a tolerable safety profile and does not deter us to doing surgeries. I think this is the concluding slide. Next slide, please. So now, are we ready for neoadjuvant treatment in currently upfront? So for me, I'm excited. I will await for overall survival benefit for someone who is having high PDL1, 4 cycles or 3 cycles of immunotherapy before surgery is something which excites me. We get a good pathological complete response. For adjuvant trials, we have different results with pembrolizumab and atezolizumab. One trial is saying that benefit is not there in less than 1% of patients. The other is saying it is there. Pembrolizumab is not showing benefit in more than PDL1 more than equal to 50%, which again is surprising. There is a theory that because in neoadjuvant we have sufficient neoantigens because we have cancer in vivo at that point of time. So maybe neoadjuvant is a better idea. Tolerance, obviously, as we see in most of the treatment, neoadjuvant is tolerated better than adjuvant. So maybe excited about it. I'm awaiting OS benefit, but in the patients who are eligible, I think this is the last slide. So if there is any question, we can take. Thank you.
Dr. Rishabh, thank you so much. for your presentation. I think giving neoadjuvant treatment with immunochemotherapy increases PAT-CR rates quite a lot, and in PAT-CR they are associated with increased EFS, but there is some concern, I think, about adverse events since the tumor is still in situ, and there is and unlike stage 4 disease, when the tumor has a immunoexhaustion kind of environment, there is no immunoexhaustion kind of environment here, and there is increased some amount of increased adverse event. Similarly, I think we also have spoken to our some of the surgical colleagues who say that once you have neoadjuvant immunotherapy, there is a lot of tumor fibrosis and inflammation, after which the surgery becomes really difficult. And there is the clinical trial with atezolizumab resulted in almost 40% more of open thoracotomies as they were not planned. So patients, they have to be shifted from VATS towards open thoracotomy. So there are really some challenges with this. The real tumor marker, whether you need to have double immunochemotherapy with nivo plus ipi, or single agent nivolumab is sufficient for how long, whether it should be given neoadjuvantly followed by chemotherapy, or you should be giving immunotherapy. Because if you give immunotherapy as a neoadjuvant treatment and then you start giving chemotherapy as an adjuvant setting, lymphodepletive, immunosuppressive, you may lose what you have achieved in the neoadjuvant setting. So, do you think that this trial is a practice-changing trial? What
So,
are looking at the
so it is still early to say that we will in all the patients. But if someone is having high PDL1, I would be tempted to give. That is what the message is. We need to await for overall survival. We still are not sure. We have different results with different trials,
yes?
and
So
even
with
the
LCM
toxicity rate is different.
Right. Very true. So with LCM M3 trial with atezolizumab, I think 10% patients have become inoperable once they were given immunotherapy as a neoadjuvant setting. So we have to be careful that our patient may progress as well.
Yeah. So these studies, that atezolizumab, durvalumab study, and even the nivolumab, ipilimumab study, I think they are with lesser number of patients, and phase 2 studies, most of them.
Right.
Checkmate is probably the one with maximum number of patients, and if adding nivolumab is not going to increase your patients who are not going to be operated, then I'm still okay. But the atezolizumab study was something which was worrisome. So if you're not able to operate a curable malignancy just because you added some drug, then that is something which we need to consider. But I think IO plus chemo would be something which will come with some benefit, because the proportion of PET-CR and major pathological response, the increase in that we are seeing, looks clinically meaningful.
So you see in that NeoStar study, there was immune flare in up to 11% or 15% of the patient in lymph nodes, and they were labeled as unresectable. So this might be a risk that surgeon may avoid doing a curative surgery in these patients just because of the patient had increased amount of tumor fibrosis and inflammation.
Again, adding ipilimumab would again lead to some increase in toxicity.
Right.
So that is something also which we should consider. So as of now, from the available study of durvalumab, nivo, ipi, atez, and nivolumab, I think nivo plus chemo is something which has the most promising data as of now. I think if we get overall survival benefit, and if it can be replicated in majority of the centers, then that is something which will tell us to change the practice. Till then, we need to wait for some time.
We have Dr. Sajjan sir here. Dr. Sajjan, your comment, please, on neoadjuvant immunotherapy before we start your session, sir.
So, Dr. Manisha, I've been listening to both of you, and I think both of you have valid points. Um, I think it needs more time for us to actually understand which is the best agent to combine in the neoadjuvant setting. So with the data which are shown with this checkmate trial, I think this looks like a more promising one. And the concerns with ATC, because I think though we understand that all the drugs are PD-1 or PD-L1 inhibitors, but still all of them have different ways by which they interact in the tumor microenvironment. So each drug should be evaluated in a manner, and also once we start using them in our own clinical practice, I think we'll become more wiser.
You said so. Dr. Sajjan is a well-known face, and he is our senior. Dr. Sajjan Rajpurohit is director in Department of Medical Oncology, PLK, Max Super Specialty Hospital, and Max Super Specialty Hospital, Delhi. Sir will be speaking on a role of immunotherapy in extensive stage small cell lung cancer. I will.
Thank you, organizers. Thank you, Manish, Rajat, for inviting me. And can I have my slides, Gitika? Please put up my slides from your side.
Yes, sir. Wait. Sir, your
So-
slide is not received right now.
What?
Your slides is not received yet.
Slides not received. They have to be given by the sponsor, Gitika. Why didn't you check? The sponsors have to.
Just wait, sir. I'll check again.
Gitika, you must be having those slides, slide deck with you. That's a very old slide deck. Okay. Yeah. Okay. Yeah. So am I audible?
Yes, sir.
Yes,
You're
yes.
audible.
Okay. So I'll be next over 15-20 minutes. I'll be speaking on evolving role of immunotherapy in early stage small cell lung cancer. Sorry, it's for can we go to the next slide? Extensive stage small cell lung cancer is where I'll be speaking over the next 15-20 minutes. So we know that lung cancer is the leading cause of cancer-related deaths worldwide, and small cell lung cancer represents almost 15% of these all lung cancer cases. So though many times in a clinical practice, we tend to ignore small cell, but then small cell is the one. In fact, when we are looking at cases in non-small cell lung cancer, we are even looking at 1% and 5% bracket of ALK MET. We should also have a important knowledge of how to best manage the small cell variety, because most of these patients, in fact, they come to us when they are already advanced. So extensive stage small cell lung cancer is the usual presentation which patients come with. Also, we have this presentation where we'll have at least 50% of these patients would have either asymptomatic or symptomatic brain metastasis at presentation. Most of these patients are elderly and they are heavy smokers. So these are the baseline characteristics which with these patients present to us. Next slide. It also known that approximately 2 out of 3 patients with extensive stage SCLC are diagnosed with expectancy which is less than a year. So by the time they come to us in the clinic, they're diagnosed, they would often have a dismal prognosis. So as a clinician, we really face the challenge as to how to prognosticate these patients. Whereas we have a patient who is ALK positive or EGFR positive, we really feel happy that these patients would be treated with pills. On the other spectrum, we have a lung cancer patient who could actually not even survive a year, and the 3-year survivors have been dismal as 5%, and 5-year survivors have been almost none, 1 to 3%. Next slide. So that has been the scenario for more than 5 decades, and there's been not much change except for cisplatin and etoposide, which first came the standard of care as in 1985, and after that we had some second-line drugs like topotecan or the camptothecin family, and then most of the drugs had failed. There was some success with nivolumab in this post multiple lines of treatment, and then there was hardly any progress for 30 years. over the last 5 years, we have had two standards of care which have come up in 2018 and 19, which are a combination of PD-1 inhibitor along with the standard of care, which was platinum with the etoposide. Next slide. Next slide. So as of now, we have in 2022, the first line treatment is a combination of a platinum-based doublet along with etoposide, prophylactic cranial irradiation and radiotherapy at physician's discretion, and the drug combination. So that has been one of the standard of cares, but then we also have first line NCCN category 1 approval for either Imfinzi plus EP or Atizo plus EP as a choices for these subset of patients. And that's over the next 7-10 minutes, I'll exactly let you know why these are the preferred compared to only a EP based combination. So once we go for an EP based combination, we have two choices. If the patient relapses more than 6 months, we could actually have a platinum rechallenge, or we could also offer a non-platinum therapy. But if the patient relapses less than 6 months, definitely we have to go to a non-platinum therapy, either in the form of topotecan or this lurbinectedin or clinical trial. So these are the current options. We hardly have any options in the second line or beyond. Next slide. Next slide. So this is a cartoon which depicts the journey of a patient. So if a patient is diagnosed in the first line as an extensive stage small cell lung cancer, then 60-70% patients will typically respond to a platinum-based doublet, but then the response is short-lived. Most patients will not respond beyond 5 to 6 months, and resulting in poor overall survival rates. The median OS is 7 to 12 months, and OS at 1 year is around 40%. Next slide. And if you just see the number of patients who are eligible for second line treatment are around 30 to 50%, and beyond second line, less than 20% patients are actually eligible or they're physically fit to get a third line treatment. So with each subsequent treatment, the number of patients who could benefit from the subsequent line become much lesser. Next slide. And this shows that the first line has to be the best line in small cell lung cancer. Otherwise, beyond first line, the number of patients who will become eligible for second or third line are dismally low. So now coming to the data with the Atizo. So if you just see, even with Atizo, if we just start with the first line, the objective response rate is 60.2%. And again, the progression-free survival for Atizo plus a platinum-based doublet is only 5.2 months. And long-term survival has not been demonstrated. If you just see, the curves slightly separate. So the curves are separated at 12 months, and by 24 months, they again are merging together. That means that 2-year OS is quite similar in both the arms. So whatever benefit is gained is over the first year only. Next slide. So if we think of these patients, then at 2 years, we don't have any survival benefit in the patients who are given Atizo along with a platinum and the platinum here uses only etoposide carboplatin. So we don't have a survival benefit at 2 years or beyond with the Atizo based EP combination. Next slide. Now, if we come to the Caspian data, because there was a landmark trial, and this was the first and the only approved IO regimen in extensive stage small cell lung cancer to allow up to 6 cycles of EP in the control arm and use of cisplatin or carboplatin. So if we just compare this to the Atizo study, so in the Caspian study, if you found that the patients actually in the comparator arm could be offered 6 cycles of any platinum, cisplatin or carboplatin. The patients had to be also, they could include patients with brain metastasis, and up to 6 cycles of chemotherapy were allowed in both the arms, and PCI was also allowed in both the arms. So if you just see, the kind of trial design of this was much better than compared to the Atizo trial. So even with all these inclusions in the study, if you just see, the primary endpoint was overall survival. That was a real good endpoint, and the key secondary endpoints were PFS, OS at 18 months, and objective response rate apart from PFS and quality of life. So all these patients, it was a large trial, 805 patients randomized 1:1:1 to 3 arms. The first one is the Imfinzi plus EP arm, and the second was only EP, and the third was actually stopped because of the non-function of this arm. So the first and second arms were important. So I'll just look at the data in the next arm, next slide. Next slide, please. So if we just compare the IMPA 133, which was the Atezo trial, carboplatin was only allowed and cisplatin was not allowed. Patients with brain metastasis were excluded, and only 4 cycles of EP were allowed in both the arms, and which is less, I would say, related to the real world use of the EP. We normally use 6 cycles in most of our fit patients, whereas in Caspian we found that cisplatin or carboplatin, based upon the patient's fitness, was allowed up to 6 cycles were allowed, and asymptomatic, untreated or treated brain mets both were eligible to be a part of the trial. Next slide, please. Imfinzi plus EP is the first and only approved IO to demonstrate a statistically significant and sustained improvement in the OS and versus the EP arm at 12, 24, and 36 months. And if we just see the arms which are the investigation versus the standard of care arm, the separation was 52.8% versus 39.3%, and at 18 months was again higher, 32% versus 24.8%, and 22.9% versus 13.9%, and also at 36 months, that is at 3 years also, the patients surviving were 3 times higher, for 17.6% versus 5.8%, and that is what is the beauty of this. If you just see the trial here, really, I would say real world data kind of a study, and having a sustained and a prolonged benefit in a subset of patients, even at a follow-up of 3 years. Next slide. And this is what is evident in both the, you can just see comparatively the IM power 133 versus the Caspian 3, you can make a difference that the separation of curves does not get say at the same level at 24 months in the IM power 133, whereas it continues to be separated and have a survival benefit at even at 3 years in the Caspian data. Next slide, please. Also, if you just see the overall survival rates, the first year are comparable, the second years are also comparable, but by the third year, the Atezo arm fizzle out, and then they didn't have any reported OS data, whereas in the 3 years OS data was 17.6% in the Caspian study. Next slide. If you just see the various across the various subgroups, the Imfinzi arm had a better hazard ratio across all the age or the sexes, performance status, smoking status, even in brain metastasis. The number of patients in the brain mets were less, but then the hazard ratios were favoring the combination of Imfinzi plus EP versus only EP alone. Next slide. Also, if we just see that the objective response rates were much higher. So even at 24 months, the objective response rates were 67.9% versus 58% in the Imfinzi arm compared to only EP arm. And the duration of response at 24 months was also much higher. So it was in the responding patients continued to respond better, and the response rates were quite higher in the responding patients. There was more than 3 times patients who were remaining in response in the Imfinzi arm compared to only EP arm. Next slide. And so the impression is that the patients who kept responding continued to respond at 12 months, 18 months, and 24 months in the patients who were in the Imfinzi arm compared to only EP arm. Next slide. So the OS based on the baseline brain metastasis, again, patients irrespective of their brain metastasis status, both the patients without brain metastasis and as with also with brain metastasis has had a continuous improvement in the median overall survival. So if you just see a patient with brain metastasis had an OS of 12 months versus 8.8 months, and without brain metastasis had a difference of 13 months versus 10.5 months in the Imfinzi arm compared to the standard comparator arm. Next slide. Again, with respect to the all cause adverse events, the Imfinzi arm, the rates of grade 3, grade 4 adverse events were numerically lower in the Imfinzi EP arm compared to only EP, and there were nominal differences in discontinuation rates due to adverse events in the either arm, and immune-related adverse events were higher in the Imfinzi arm compared to the EP, and that is known and most common was thyroid-related events, and majority of immune-related adverse events were low grade and managed with in lines with standard treatment guidelines. So the addition of Imfinzi to EP was quite manageable with no major increase in chemotherapy-related side effects. There were some adverse events related to immune relations, and they were managed with standard treatment guidelines. Next slide. So again, if you just see the rates of febrile neutropenia, pneumonia, anemia, thrombocytopenia, you can just see that they were in fact lower. Many of them were actually lower in the Imfinzi EP arm compared to only EP arm. Next slide, please. Also, with respect to all the quality of life as well as cognitive, emotional, physical, and role functioning, all favored the Imfinzi plus EP arm. So the quality of life was well maintained. In fact, doing much better in the Imfinzi plus EP arm compared to only EP. Next slide. So with respect to the side effects, you can just also say that time to symptom duration from the baseline also were much better in the Imfinzi plus EP arm only compared to the EP arm. Next slide, please. So the Caspian demonstrated Imfinzi could be administered every 3 weekly with EP and Q4 weekly as a maintenance. So with chemotherapy, it was given 3 weekly, and after that it was given 4 weekly. It was very convenient for these patients to follow up with the maintenance dose of Imfinzi vis-a-vis Atizo. Next slide. So if you just see, the most important thing was that if we just compare to IM power 133, brain metastasis was not allowed, and PCI was allowed, and up to 6 cycles were allowed, and cisplatin was allowed. So and one more thing which was important was that PCI was excluded in the experimental arm, and in fact most patients could do well without PCI in the Caspian study compared to IMP 133. So the patients were allowed treatment either with cis or carboplatin. It include patients who were having asymptomatic or untreated patients with brain metastasis, and were compared to given 6 cycles with the optional PCI. Next slide. Next slide. And that's what brings us to the NCCN guidelines, and they have approved this as the category 1 recommendation and one of the options for our patients. But based upon these data, the clinicians have to decide which are the better combinations to be given in the first line setting. Next slide. So to conclude, first line durvalumab EP has shown sustained an improvement in OS compared to robust control arm that is reflective of the real world scenario, allowing up to 6 cycles of EP with the use of PCI as compared to the results with Atizo and carbo etoposide. And durvalumab is the only IO that has flexibility for choosing cisplatin or carboplatin along with etoposide, and benefits of durvalumab EP were observed across all subgroups, including brain metastasis. More than 17% of patients with durvalumab EP were surviving at 3 years, showing almost triple the survival benefit compared to the comparator arm. And durvalumab offers convenient once monthly dosing for maintenance phase, and safety findings were consistent with known safety profile of durvalumab plus EP. Thank you so much.
Thank you, Dr. Sajjan. So that was really nice. So, so what is your combination chemotherapy with durvalumab? So, do you prefer using cisplatin or carboplatin? And second question, what is the current status of PCI and chest irradiation after we have atezolizumab or durvalumab in our armamentarium along with chemotherapy in extensive stage small cell lung cancer?
So if a patient is less than 65 years, no major comorbidities, I prefer cisplatin. Beyond 65, I go for carboplatin. I offer them, I begin with in my mind of having 6 cycles, but if the patient is doing well, then I might just end up at 4 cycles and continue durvalumab based upon case-to-case basis. PCI I have been avoiding in my patients because of the cognitive deterioration with the PCI. I would like to reserve it later, especially the patient doing well. And yes, consolidation to the local site, it has responded really well. I'm doing for my patients.
So, sir, with consolidation, immunotherapy along the consolidation mediation. So, I think is it toxic enough? Is it tolerated well?
Yeah. So again, it depends upon what kind of a response the patient has got. I would say the patient only got the extra pulmonary disease is not much. the patient has responded very well, and the field which the patient has to be rated is not that big, then yes, I would go. Otherwise, again, I'll have reservations for use of radiation. I'll continue only durvalumab in such patients.
Right. So, I think we have trials which have compared just the observation vis-a-vis MRI brain every 2 to 3 months, and you can safely avoid PCI for the patients if they understand that they can be well kept under observation along with MRI. Sir, your experience with atezo or durvalumab in this setting, sir?
Sorry, I lost your connection, Manish.
Sir, your any experience with this atezo or durvalumab in this setting, sir? Any patients?
So I've been using durvalumab as my preferred combination for such patients.
Okay, sir. So the toxicity and the tolerability is okay, right?
So I would say that does not really have major difference, but though some patients, 5-10% patients do have thyroid disorder abnormalities. Otherwise, the combination is well tolerated.
Sir, I think few of my patients have this combination, and fatigue is one of the issue which I frequently encounter with this with treatment. With extreme fatigue, I have observed that the patient have when they are given chemotherapy along with immunotherapy. One of my observations.
I agree with you.
Thank you so much, sir. So we have next speaker, Dr. Abhishek C. Kakru. So Dr. Abhishek is medical oncologist at HOC Vedant Hospital, Ahmedabad. This session is sponsored by Eli Lilly. So NSCLC adenocarcinoma, we have EGFR mutations, and there are plenty of options around the patient now. So we'll be discussing about the relay trial, what information will help you improve our treatment decisions in EGFR mutant advanced NSCLC, relaying the relay. So I welcome you, Dr. Abhishek. Please go
Thank
ahead.
you. Thank you, Mr. Manish Bhai. And first of all, I'd like to thank all the organizers for this opportunity. We'll not only be discussing about relays, but it is important to realize, which is probably the crux of the lecture, that EGFR is not a single disease. So it is now at least 18, 19, 20, 21. We have 4 diseases which need to be tackled differently. So can somebody share the slides? Yeah, you can make it. Yeah. Next. Next slide. So these are the disclaimers. Next. Yeah, you can move on to the main slide. So basic question is, there are a few questions which need to be addressed. One is whether EGFR is a single disease which we used to, which we like to treat. So you like to give Jeftinib and osimertinib to everybody. Once you see EGFR, you are really happy. A patient has landed up with a EGFR mutation, but it's not a single disease. And so the question is whether we need information. You need just the information that a patient has a EGFR mutation, or you need a lot of other things to realize what should be done with this patient. Next slide. So let us start with a case, a typical case. She's a female non-smoker, stage 4 adeno-CA lung, has comorbidities in the form of diabetes and typical symptoms of cough, dyspnea, weight loss. So the next question would be, next slide. Question would be, what do you do? So basically, you got the biopsy as adeno-CA. I think our previous speakers had already discussed, and some discussion was going on previously also. So 2 things are important. One is whether you do a targeted mutation in the form of your EGFR AL cross, or you send an entire NGS. So the debate continues, but probably you'll see a few slides towards the end why NGS is more important than just predicting whether the patient is EGFR positive or not. And again, whether a brain MRI should be done prophylactically in every patient, or whether you should do it in patients who are symptomatic. So we know that it should be done if the patient has symptoms. We don't do it prophylactically as far as NSCLC goes. And obviously, patient and NGS was sent. Next. So since the NGS came out to be EGFR positive, and it was L858 mutation, which is exon 21 mutation. It is pathogenic. It's a driver mutation. Next. So then, as I was previously alluding to, whether you are looking at patient as a deletion 19 or an L858 21, these are the two most common. So majority, let's say about more than 90% of the patients have either of these two. The others 18, 20 make up like hardly 2-3% of the mutations each. So point is whether you treat both of them the same way, or it is time that you differentiate between the two and you treat them according to their merits, and as well as other information that might come with these mutations as well. So next slide. Go to the next slide. So this is the entire spectrum. It's a common slide. We have all seen this EGFR. You can see from 18, 19, 20, 21. So you can see the L858 is about 41%. Previous slide, please. Can you go to the previous slide? So you can see the common ones. Next slide.
Okay, sir.
I think I should take the control. Yeah, this one, please. So, so forget it. So basically what I was alluding to is that 19 and 21 are the most common.
Share your remote control, sir.
Can you hear me?
Dr. Abhishek, you are audible.
Yeah, so somebody's talking, so there was some noise in the background. So we are looking at main issues.
Yes, sir, I can hear you.
Yeah, so 19 and 21 make up the major crunch of it. And the other rare mutations is 18 and 20, which again, all these mutations need to be probably looked at differently. So the question is, what do you, this is EGFR all that you want to know, or which mutations are involved, or which co-mutations are involved with that? Next slide. So this, I can't see the slides. Yeah, next slide. So next slide, yeah, go ahead. So what is important is, first of all, we need to differentiate that 19 is not the same as 21. So we like to treat everybody with an osimertinib or a geftinib. So there is clear enough data to suggest, this is a meta-analysis from 6 studies, more than 1300 patients, to suggest that EGFR 19 mutation is better than EGFR 21. Next slide, go ahead. So you can see, if you are seeing a patient of 19, significantly reduced risk of disease progression compared to your 21 L858. Next. And again, this is another meta-analysis suggesting the same thing. These are 7 studies and about 600 patients suggesting. Next slide. Go ahead. Yeah, so there's a significantly reduced risk of disease progression in 19 compared to your 21. So we all know that. Next. What is important is co-mutation. So this is a Chinese study which I put up, about 60 cases. And what it suggests is that you can see from the left-hand side, the green bar is your L85821. The number of co-mutations is much higher in exon 21 compared to your exon 19 mutation. And once the co-mutations are higher, you can see from the two graphs that the progression-free survival as well as the overall survival in patients who did not have a co-mutation, it was better rather than in the patients who had a co-mutation, suggesting to the fact which I was talking to, not just L858, even the other information which is picked up by NGS is important, because the number of co-mutations also affects your PFS and OS. And the other fact is that 21 has more co-mutations than deletion 15, probably one reason why 19 is doing better than 21. Next. Highlighting the same fact. So these figures will tell you the same thing. The tumor mutation burden in 19 is much lower than in 21 L858. Next. So then the question is, what are the options do we have? So we have the first generation, the second generation, and the third generation TKIs. What we have different recently in the last year or so, in 2021, we had the relay trial suggesting that a TKI with a VEGF inhibitor like a ramucirumab gave you equally good results in both 19 mutation as well as exon 21 L858 mutations. Next. You can move on. So this is data across all the first, second, and third generation EGFR TKIs. And this is all the data we have as of today, major trials suggesting that a first generation TKI, the second generation TKI, and the third generation TKI, obviously it is better than chemotherapy. We know that. And the first generation have a median PFS of around 9 to 12 months. The second generation had a median PFS of about 11, 12, 14 months. And the third generation had a median PFS of about 18 months. Again, this is the first generation trials, next, second generation, and the third generation. Next. So what about the two combinations? You have a combination of chemo with a TKI, and you have a combination of a VEGF inhibitor in the form of bevacizumab or ramucirumab with a TKI. Again, suggesting the same thing. So chemo with a TKI, you had a median PFS of about 16 to 20 months in a couple of trials, and VEGF with a TKI, you had a median PFS of about 16 to 19 months. Next. An important, see, this is the most important slide, again highlighting the same fact. So this is your third generation TKI, the first part Flora, second generation TKI, as well as the first generation TKI, and the last part of it is decometinib, the Archer study. So what this slide shows you is in exon 19, you can see the PFS, all of them are doing better. So the PFS in Flora for the exon 19 was 20.4 months compared to your L858 where it was only 14 months. Similarly, in your afatinib, it was 13.8 months compared to 10.8 months for the exon 21. And you land up with your erlotinib, it is 11 months in the 19 compared to 8.4 months in your exon 21 L858. Decometinib, it was 16.5 months PFS in the exon 19 deletion compared to 12.3 months in the exon 21 mutation, suggesting that, to summarize it, if I have to say, most of these trials, exon 21, the median PFS was anywhere from 12 to 14 months, not more than that. Exon 19, they had a beautiful survival from 16 to 24 months in the Flora study. Next. So what do you have anything else which can make a difference? So then comes the relay study where we added Cyramza to this TKI. Next. First of all, you need to realize why the entire concept came from. So preclinically, it is shown that EGFR mutant tumors are more VEGF dependent and than the VEGFR wild type. So a dual VEGF and EGFR pathway blockades definitely enhances the efficacy. EGFR mutations result in upregulation of the VEGF as well as the HIF1. And you can see that in the mouse models, and EGFR inhibition itself lowers the VEGF levels via the HIF1 dependent pathways as well as independent mechanism. So basically, even mutation or resistance to EGFR leads to upregulation of VEGF pathways. So makes sense. So it is one of the pathways involved in an EGFR mutant guy, and blocking both definitely adds to the response. Next slide. So this was the earliest, the beta study, which suggested, so you can see the EGFR wild type, this was using bevacizumab with erlotinib compared to just erlotinib alone in EGFR mutant patients. And what they picked up is that in the EGFR mutant guys, you can see the HR is 0.44 compared to your wild type guys where it is 0.97. So the only patients who were doing better were the EGFR mutant guys. Next. Again, this is the summary of most of the studies you can find with an EGFR together with the bevacizumab, or the first generation you had VEGF inhibitors. So you can see this is second line, first line studies. Median PFS was anywhere from 9 to 13 months, and in the single TKI arm, adding bevacizumab resulted in the PFS from anywhere to 16 to 17 months. So definitely the HR improved, the PFS improved by addition of a TKI, VEGF inhibitor. Next. Again, highlighting the same fact which I told you previously, that there are models, mouse models, as well as plasma studies showing you that the VEGF levels are higher in these patients, and inhibit definitely at the time when the resistance develops to a TKI, and adding a VEGF inhibitor makes sense. Next. Another rationale for doing this combination is once you have used a VEGF with a TKI, so as in the case with a single agent TKI, you ultimately land up into a T79M mutation. So about half of the patients would have a T79 mutations if you have treated them with erlotinib with a ramucirumab. Similarly, the T79 mutations would be about half of the patients would land up post even single agent TKI. So you still have an option of using osimertinib in these guys post your first line combination of erlotinib with ramucirumab. Next. So this is the possibly the best and the only slide which summarizes everything. So you can see the first generation TKIs, you had a median, as I told you, PFS of 9 to 12 months. If the patient progressed, depending on T79M mutation, positive or negative, you had an option of using osimertinib versus using a chemotherapy with a immunotherapy or a bevacizumab. So you had about, let's say, 9 to 12 months with the first line, you had about another 8 to 10 months with the second line. So probably you achieved around 20-25 months. What about your third generation TKI? So with the Flora, you achieved about 19 months PFS, and second line you added chemo plus bevacizumab or an immunotherapy, you could achieve anywhere from again 20 to 35 months. What about using first line erlotinib with ramucirumab? So you achieved a median PFS of about 19 months. And if the patient was T79M positive, as would happen, you had an option of using osimertinib. You had a second line in the form of osimertinib, and you had a third line in the form of, again, chemo with an immunotherapy available, probably leading to a better overall PFS or a longer PFS with this combination. Next. So there would be always people arguing in both sides. There are merits to using a third generation TKI. As you can see, I have highlighted both sides of it. So osimertinib, single oral medication, well tolerated, would have CNS efficacy as well. What about erlotinib with the ramucirumab? So again, outcomes are comparable. We have the same median PFS of about 19.4 months. You have a T79M, you could use a osimertinib and then a chemotherapy, immunotherapy in the second and third line. So leading to a more longer PFS in these patients. So it is basically a discussion between the two. Important thing is that if you have a patient with L858, probably even osimertinib would give you a shorter PFS compared to your TKI plus ramucirumab. So you're probably looking at a subset of patients where you should be tackling them a bit differently. Next. Again, highlighting the same fact, if I have to summarize the relay side in relay trial in one slide, you can see the exon 19, the median PFS in the single agent TKI arm was 12.5 months compared to 19.6 months when ramucirumab was added. And important thing is exon 21. So exon 21, you are looking at poorer survival. So it was about 11.2 months for the erlotinib arm compared to 19.4 months in the ramucirumab with erlotinib arm. So what happened is, in both, irrespective of L858 or exon 19, the combination did better, and you had a median PFS of about 19 and a half months, which was probably similar to your third generation TKI, which is osimertinib. Next. So again, highlighting the same thing. Next. So then the question comes. So as I told you, 19, probably you might still opt for your conventional TKIs and osimertinib would be fine. What about 21? So 21, now you need to think hard whether you should be using osimertinib, whether you should be using a erlotinib with a ramucirumab as an option. Next. So again, I had in my initial few slides I had told you. So important thing is you should be knowing, probably more information is confusing, but there is data to suggest that more information about the co-mutations will definitely help you decide on the treatment as well as decide on the prognosis of this patient. So a number of co-mutations are found when we use NGS, and these co-mutations are definitely affecting the response or the PFS of these patients with EGFR mutation. I had shown a slide previously also. Next slide. So co-mutations are found. You can see, as I had previously told you, in exon 21 mutations, the number of co-mutations are much higher than in exon 19, but both exon 19 and exon 21 will have co-mutations. And what do these co-mutations do? Next slide. So very well elaborated in this slide, you can see if in a patient who had co-mutation and a patient did not have a co-mutation, you can see the PFS is definitely different. So in a progression-free survival without a co-mutation was 18.7 months compared to just 6 months to a patient who had several co-mutations, and overall survival also made a huge dent. So it was 22 months in a patient without any co-mutation compared to compared to a very meager, it had not reached compared to 22 months in a patient who had multiple co-mutations. So knowing these co-mutations is important. Obviously, you need to know which type of mutations are affecting the overall pathway. I'll give you one example. Next slide. So TP53, which probably we find in most of the NGS panel, even if you don't find anything, TP53, RB, NF1, you probably land up with these mutations in most of your NGS panels. What is interesting in EGFR mutant NSCLC is that TP53 in an EGFR mutated patients, you will see in both at baseline as well as at the time of transformation. And TP53 alterations have been associated with a favorable response to, again, a VEGF inhibitor or a VEGF receptor antagonist, which is your ramucirumab or an anti-angiogenic therapy. So it definitely might prove as a predictive biomarker to a response to anti-angiogenic therapy. Next slide. So again, highlighting the same thing in the relay trial, the prevalence of TP53 mutation at baseline was about 40 to 43%, and at progression was 17 and 50% in both. So exon 19 and exon 21, both cases you had TP53 mutations. And what is heartening is in patients with TP53 mutations, the combination showed a superior PFS compared to your placebo with a TKI erlotinib in both exon 19 and exon 21. So combination of ramucirumab erlotinib definitely showed a consistent benefit in both patients who had TP53 mutations as well as who did not have a TP53 mutation. Probably highlighting the fact that this VEGF pathway is activated in these TP53 mutated cases, and suppressing this pathway is definitely adding to your PFS. So next slide. Again, it's the last slide. So I'll just summarize again that most of the EGFR mutations you can pick up in your NGS, but picking up these Q mutations is important. Secondly, each of these EGFR mutations, so we are not discussing your exon 20 insertions, your exon 18 mutations, because then this lecture would never end. But most of these patients would have to be addressed differently. And there needs to be a thought when you are treating each of these patients, and especially exon 21, which we see quite a lot in our practice. Exon 19 is easy. We are all happy. You have a good PFS in these patients. Probably you need to look harder for your exon 21 guys. Thank you.
Dr. Abhishek, good evening. Thank you so much. That was a wonderful presentation. I think Dr. Rajat is also here. Okay, yes.
Yeah, so I had put up a slide. Osimertinib would do a slightly better in the brain mets, guys. So again, it has to be a discussion with the patient, but then you have two options now. Probably you have two combinations, two options. So people might argue on both sides. So you might argue that osimertinib, then I'll give chemo and immunotherapy. Somebody might argue that, as I have argued, that I would like to give a VEGF with a ramucirumab with a TKI first, and then look for T79 and give, then lastly give a chemo immuno, because I want to pull my patients much longer. So I think you can argue both ways. There's no end to that argument. But again, brain mets, probably your osimertinib would score over this combination.
So yeah, exactly. My point is that if we are talking about this combination is an excellent combination. There is no doubt about it. A PFS which is even superior to osimertinib. So what else would you want? But then, and of course, a very important point that you can use osimertinib post this combination so that it improves the overall survival. We all know as medical oncologists that we have to sequence our armamentarium drugs in a way that it increases the OS. But the only issue probably I'll be wary of using this combination is in a patient of brain metastasis,
Yes.
even if it is exon 19, even if it is exon 21, even then brain metastasis, we have hugely gaping curves of osimertinib, and probably that is the only subset. Other subsets, I will definitely want to give this option to my patients.
Yeah, agreed, fully agreed.
Dr. Rajat, I think the specific property of osimertinib, which is the penetration, that is one of the most important thing. The discussion with the patient whether he wants IV chemotherapy, IV treatment, or oral, simple oral is also very important. Similarly, the presence of L858R you cannot neglect. Clinical trial shows clearly that osimertinib has less amount of uh, benefit in L858R, and you can see that the subset analysis also shows that Asians, they had less benefit. So I think relay trial is an important treatment aspect, but we cannot downgrade osimertinib because it has got real brain penetration. Real discussion with the patient family regarding the logistics also needs to be kept in mind.
So if you look at all the TKIs available in L858, I think most of them did not do fare well. So they did well, but not as compared to your exon 19. That is one reason which compels you to look into the relay data.
The other issue is OS data. OS data is yet to mature, so that also is a little concerning. Apart from that, there are many positives to this particular combination.
Yes.
Right. I think I thank Dr. Abhishek for again taking us through this very important data set, and thank you very much for being a part of this webinar. Please continue to be with us for the future discussions. So we move
Pleasure.
ahead. The next topic is going to be on the role of atezolizumab in the first line setting in metastatic NSCLC. And I am going to take up this talk, and in the next 20 minutes or so, we are going to discuss what is the best treatment for first line NSCLC now, especially in patients who are not having a driver mutation in the very beginning. Next slide, please. So these slides have been given to me by Roche, who's the sponsor of this session. This is what we are going to discuss: the little background about NSCLC, what is the evolving landscape. The three studies that I'm going to speak about is IMpower 110, 150, and 130, and later will be the summarization. Next slide, please. So we do know that NSCLC is a very important malignancy. If we talk about in our daily practice, about 80 to 85% of all lung cancers are NSCLC. Lung cancer is really there at the top if you talk about the Indian data or the world data in Globocon 2020. The median age is always on the higher side, 65, 70. Most of these patients present at a late stage when the patient is already metastasized to the malignancy has metastasized to other parts of the body. And these patients can have histology of squamous or non-squamous, and most common non-squamous histology is adenocarcinoma. Most of these patients are smokers and will mostly have a histology of squamous histology, but there are about 15 to 20% patients who will have a never smoking history, and these are the patients where mostly the histology will be found as adenocarcinoma. We do understand and know that adenocarcinoma histology has a better prognosis compared to a squamous histology. Next slide, please. Yes, there have been instances when the treatment of lung cancer has changed, and there has been a paradigm shift in the last decade or so, or maybe 15 to 20 years now. Previously, there used to be only the option of chemotherapy, and after that, chemotherapy plus minus anti-angiogenic drugs. Then came the era of targeted therapy post 2007, when Dr. Tony Mock told us about the EGFR mutations. And then there has been a host of targeted therapies which have come up for oncogenic driver mutation positive patients. But very importantly, we are talking about immunotherapy here, and we are talking about those subset of patients who do not have oncogenic driver mutation in the very beginning. Next slide. So it is very clear that if a patient has an oncogenic driver mutation, then the survival is definitely better as compared to patients who do not have an oncogenic driver mutation. And the Kaplan-Meier curve on the left-hand side of the screen tells us this very clearly. Also, very importantly, one has to understand that if we have a pie chart, which is on the right hand side of the screen, regarding the oncogenic driver mutations, most common mutation is the KRAS mutation, followed by the EGFR mutation. But look at the pointer, about 35% of the patients will not have any oncogenic driver mutation. So what about them? Why are these patients really being left out as far as the clinical trials are concerned? Probably in the last 3-4 years they've been addressed, but then before that there was not much talk about these patients. These 35% patients is like 1/3 of the whole gamut of patients. And can we do something to improve the survival of these patients as well, is what we are going to talk about. Next slide. So certainly, like I said, that there is an important need to address these 1/3 of the patients, and these patients have been addressed in 3 studies as far as the first line use of atezolizumab, either alone in a particular subset of patients or in combination with chemotherapy is concerned. And these are the 3 studies that we are going to speak about. First study that I am going to talk about is the IMPAR 110 study. Next slide, please. Next slide, please. So this study enrolled both squamous and non-squamous histology patients, very importantly, and it was this was a study design. It was a stage 4 non-squamous or squamous NSCLC patients. Remember, all of them had to be EGFR and ALK negative, very particularly. And PDL1 selected population, they had different grades of PDL1 expression. We'll just talk about that. And then they were randomized 1:1 to receive either atezo monotherapy, 1200 milligram Q3 weekly as a standard dose until progression or toxicity, or if it was the control arm, it was chemotherapy, and chemotherapy could be gem platinum in squamous or pemetrexed platinum in non-squamous, followed by pemetrexed maintenance. This is what the thing was, and primary endpoint was overall survival in the whole population. Next slide, please. So very importantly, like I said, that they had a graded PDL1 expression. So you have to understand that there were about 35% approximately patients in both the arms who had a PDL1 expression which was on the higher side, that is more than equal to 50% if we look at the tumor cells, or more than equal to 10% if we look at the immune cells. And then there were patients who had a lower expression, intermediate and low expression as well. We are going to speak about the subset of patients who had a very high PDL1 expression, that is tumor cell population more than equal to 50%. Next slide. If you look at the baseline characteristics, they were well matched. Most of these patients had a non-squamous histology, like I mentioned in the beginning. Most of these patients, some of these patients were Asian ethnicity, and most of these patients had a good performance status of PS0, and they were both well balanced and matched between arm A and arm B. Next slide. So I said that the primary endpoint was overall survival in the whole population, and this was the secondary endpoint, which was the overall survival in the high PDL1 expression group. And look at the overall survival. There is wide gaping of the control arm and the experimental arm, and this is the overall survival Kaplan-Meier curve. If you look at the 6-month OS and the 12-month OS, then there is certainly a very important difference, with the hazard ratio being 0.59 and the p-value being highly significant at 0.0106. And the median OS was 20 months in the atezo monotherapy arm compared to 13 months in the chemotherapy arm. So a delta of 7 months with a high PDL1 expression makes this a positive study. Next slide. And if you look at the OS in the key subgroups, this were pertaining to the high PDL1 expression, then whether the patient had a squamous or a non-squamous histology, both of them benefited. If you look at whether the patients used to smoke or not, all of them benefited. And even the even the PS01, they benefited. So which means that it was a positive study, and a squamous or a non-squamous histology population with a high PDL1 expression, we may not give chemotherapy and resort to a atezo monotherapy and aim to achieve a higher OS compared to only chemotherapy. Next slide, please. If you look at the subsequent treatment, if the nearly 1/3 of the patients in the even then crossover was there, and good number of patients achieved subsequent immunotherapy, and still the benefit was maintained. Next slide. If you look at the PFS also generally, it may not be seen in an immunotherapy trial, but here the PFS also was significantly better, 8.1 versus 5 months in the favor of experimental arm. Next slide. And even the response rates to approximately 40% versus 28%. So this also was significantly better, more the number of responses if we have a high PD-L1 expression and using atezo monotherapy. Next slide. The updated safety analysis tells us that yes, in the atezo arm, there are going to be more immune-related side effects, but that is understandable, and there nothing alarming was really found out. And this is something that over the years we have already learned to how to use immunotherapy, and this was manageable. Next slide. So if you look at chemotherapy, more of anemia, more of nausea, neutropenia is certainly bound to happen. More of transaminitis is there in the immunotherapy arm, and more of IRAEs, like I said, but they were manageable. Next slide. So the conclusion of IMpower 110 is that if you are going to speak about atezolizumab as monotherapy, it certainly was a positive study. If you are looking at the PDL1 high subset of NSCLC patients, this was both the histology is very important to remember, squamous or non-squamous. We don't have to bother. If we have a high PDL1 expression, we can easily use atezo monotherapy. Higher response rates, higher PFS, and certainly the gold standard endpoint overall survival also was high, with the HR of 0.59 and p-value being significant. The safety profile was also manageable, and the patients had a longer treatment exposure than patients who were treated with chemotherapy. Next slide, please. After IMpower 110, we have IMpower 150 now, and this is pertaining only to non-squamous histology, a phase 3 study where atezo plus chemotherapy plus bevacizumab also, that is ABCP regimen, was used in the first line in non-squamous NSCLC patients. Can we have the trial schema, please, in the next slide? This is the trial schema, and if you look at the trial schema, again, stage 4 NSCLC patients, non-squamous histology is a very important point, and these patients were chemo naive, and they were randomized to 3 arms. One was the control arm, which was paclitaxel, carboplatin, and bevacizumab. There was a second arm, which was paclitaxel, carboplatin, bevacizumab, and atezolizumab, and the third arm was atezo plus paclitaxel. And all these arms, they had a maintenance according to the protocol. And if you see the atezo plus bev plus paclitaxel arm and the paclitaxel plus carboplatin plus bevacizumab arm, they are category 1 recommendations. So it was a very well designed study where they were trying to compare the 2 category 1 recommendations by NCCN and pitch them against each other and try to see the co-primary endpoints being the PFS in the intention to treat population and OS in the intention to treat population. Next slide, please. Very important to remember that all these patients had EGFR and ALK negative. Like I said in the beginning, these are trials in the oncogenic driver mutation negative patients. We do understand that there is a rationale for using atezo plus bevacizumab combination. Bevacizumab is a VEGF inhibitor. It inhibits the dendritic cell maturation, and it also normalizes the tumor vasculature. What it does is that it decreases the activity of the stem cells and the T regulatory cells. Chemotherapy-induced immunogenic cell death can trigger the release of tumor neoantigens, and once the tumor neoantigens are released, then the mechanism of action of atezolizumab is exactly on those, and that is why it improves the action of atezolizumab. Next slide. So the baseline characteristics, they were well matched between all the three arms. Very importantly, one has to remember that they were mostly patients who were having a good performance status. All these patients are non-squamous histology, as we have already discussed. About 50% patients had a high PD-L1 expression. Very few of the patients had EGFR and ALK as well. About 10% EGFR, 2 to 3% ALK, and then very importantly, about 15% of the patients had liver metastasis in the beginning, and they were all well balanced between the three arms. Next slide. So this is the endpoint, which was the overall survival. And overall survival, as you can see, the control and the experimental arms, they have a good separation of Kaplan-Meier curves, be it the landmark OS of 12 months, 18 months, or 24 months. And there is a steady improvement in overall survival with a hazard ratio of 0.80 and a median OS of about 20 months versus 15 months, a delta of 5 months at that. This is comparison between arm B, which is atezo plus bev plus pacli carb, with arm C, which is bev plus pacli plus carb. So this is a very robust data, because bev plus pacli plus carb also has been used in many trials, and one or two trials have shown that there is OS benefit of using bevacizumab. So over and above use of bevacizumab, if we add atezo, and this is remember, in patients who are all comers, these are patients who are having any amount of PD-L1 expression, but they have to be a non-squamous histology. Atezo plus bev plus paclicar combination is been seen to have an improvement of OS compared to bev plus chemotherapy arm. Next slide. The response rates also, they are higher in ABCP regimen, and of course the response rates are the highest if you are going to talk about a very special subgroup of selected PDL1 high patients. But then even if we talk about the intention to treat population, 56% response rates was never seen with only immunotherapy. We just saw IMPAR 110 where the response rates were about 38%. So certainly addition of a bev plus atezo plus chemotherapy has increase the response rates to in excess of 55%. These are the response rates which you expect from a TKI, but then this is what we see here, which is certainly a very heartwarming for an oncologist. Next slide. Even the OS, if we see, it was observed across all the subgroups. Of course, the quantum of benefit was the highest in the PD-L1 high, but then if the PD-L1 was low, even then the benefit was maintained. Next slide. So what about patients who are EGFR mutant? So these patients, of course, had received EGFR TKIs in the beginning. Next slide. So this was in the second line that it was being used, that is ABCP regimen. We do understand and know that these patients are underrepresented in most of the clinical trials. This was a trial where they did have a representation. About 10% of these patients were there in this study. Next slide. And if you look at, although a small number, but if you look at the Kaplan-Meier curves, we see that if you look at the progression-free survival, it was about 9.7 versus 6 months. So and it was statistically significant. If you look at the hazard ratio, it was 0.59. So an important take home, that if we have a EGFR mutant subgroup of patients who have had a progression on EGFR TKIs, then probably these patients can be given this combination, and an improvement of PFS against the standard bev plus pacli plus carb can be expected. Next slide. There is another subset of patients. So even the OS was improved in these EGFR mutant patients. Next slide. There is another subset of patients which is the response rates also were improved. Next slide. About 5% of these patients, including this, also generally do poorly, and also are these patients will have a shorter OS and PFS. Next slide. And we see that even in liver metastasis patients, this combination was working well compared to the control arm. And if you look at the PFS was higher, and the delta of PFS between, next slide please, delta of PFS between ABCP versus bev plus paclicar was higher. And we look at the Kaplan-Meier curves, they are separating widely. Next slide. Even the OS benefit was there. If you look at the liver metastasis. Yeah, next slide, please. Next slide, please. Response rates also were higher in early separation of Kaplan-Meier curves. Again, is a very reassuring point for us that even with liver metastasis patients, next slide, which are considered conventionally bad patients, this combination has been seen to improve the overall survival. So in key subgroups, next slide, be it a bulky disease patient, be it a patient where there is, next slide, where there is EGFR mutation, be it a patient where there is liver metastasis, this combination has worked very well. Next slide, please. So if you look at the efficacy of high and low volume disease, even in patients who are having a low volume disease, this combination worked. But then in patients who had a high volume disease, again a proverbial bad subset of patients, these patients again did well with this combination. So this combination is basically an axe which you can use to solve a lot of your difficult subset of patients. Next slide. Next slide, please. The tolerance also was good. We can skip this in the interest of time. Next slide. So the conclusion is that this is a positive study with which it met its primary endpoint. First line use of ABCP regimen is the standard of care now, and clinical benefit was observed across key subgroups, and especially patients who are actually known to not do very well. Next slide. Next slide, please. Now we are going to speak about the IMPAR 130 study. Next slide, please. And IMPAR 130 study actually is a study again in the non-squamous histology setting. And next slide, please. Next slide. It is a phase 3 study of nab-paclitaxel and carboplatin with or without atezolizumab in the first line NSCLC patients, again non-squamous histology. Next slide, please. So this is a combination of atezo plus chemotherapy. There's going to be no bevacizumab here. And this is the trial design. Again, NSCLC patients who are non-squamous histology, PD-L1 H expression stratified with a good PS and EGFR ALK being negative. Patients of liver metastasis were allowed. About 700 odd patients. They were had a 2:1 randomization to receive either the control arm of chemotherapy, which was nab-paclitaxel carboplatin, or it could be nab-paclitaxel carboplatin, or if the pemetrexed was given, then pemetrexed maintenance, and the other could be atezo plus nab-paclitaxel plus carboplatin, followed by atezo as maintenance therapy till progression or unacceptable toxicity. The doses were very standard, which was used. The use of nab-paclitaxel actually was to provide a potential steroid-sparing chemotherapy regimen. Next slide, please. The co-primary endpoint was PFS in the intention to treat population and OS in the intention to treat population. A well-balanced based on characteristics in both the arms, where we see that liver metastases were present in about 15% of the patients, about 15 to 20% of the patients in both the arms had a high PD-L1 expression. About 50% of the patients were PD-L1 negative as well in both the arms. Next slide. This is what we actually saw when we look at these results. The PFS was improved in favor of atezo plus nab-paclitaxel carboplatin as compared to only nab-pacli-carb in the intention to treat population, with the 12-month OS being the 12-month PFS being 42.5% versus 14%. So nearly that 3 times of PFS was seen with the atezo plus paclitaxel carboplatin. If we talk about the median PFS, it was 7 months versus 5.5 months. Next slide. If you look at the OS, even OS was significantly better. OS of 40% versus 30% in 2 years, and the median OS was about 19 months versus 14 months. The delta of 5-month OS was seen. Next slide. There were about 40% patients who crossed over to the atezo arm in the chemotherapy alone arm, but still the OS was seen. If you look at the subgroup analysis in the forest plot, again, you see that this was all restricted to the non-squamous histology. The highest PD-L1 expression, they also benefited. The PD-L1 low expression patients also benefited, and patients who were having liver metastasis, they benefited more than patients who did not have a liver metastasis. Next slide. So very importantly, in this population, there were very few EGFR and ALK positive patients, but they did not have the benefit of the addition of atezo to chemotherapy. Next slide. Even the response rates were improved with atezo combination as compared to only chemotherapy, be it the intention to treat population or the high PD-L1 expression population. Next slide. And the safety profiles also were consistent with all the previous trials that we have discussed. Next slide. So important conclusion is that this is again a positive study in non-squamous histology patients where atezo plus chemotherapy can be added to chemotherapy alone, and this would result in an improvement in overall survival. These patients had a manageable safety profile, and but this combination was not proven to be effective in patients who were second line EGFR or ALK positive patients post the use of TKI. So we have to carefully select our patients who would really benefit out of this particular combination of IO plus chemotherapy. Next slide. Yeah, so with this, I thank you all for your patient listening. The important summary is that atezolizumab has got an important role to play in the first-line metastatic NSCLC patients. We should use this combination while carefully selecting our patients so that the benefit of IO, either in a monotherapy or in combination, can be passed on to our patients. Thank you. Now, I would like to invite Dr. AVS Suresh. Dr. Suresh is a senior consultant, medical oncology and hematology and Continental Hospital, Hyderabad. Dr. Suresh is going to take us through what are the new ASCO updates which have come in this year, ASCO 2022, as far as the lung cancer is concerned. Dr. Suresh, over to you.
Thank you, Dr. Rajat. First of all, thanks for giving the opportunity. We had a lot of positive trials, but whatever 4 trials that I'm going to present are not so positive in terms of their outcome, but very positive to tell us what not to use. So everything is having a meaning in the research, right? So the first is to compare the quality of life in patients randomized to receive high dose once daily thoracic radiotherapy versus standard twice daily. This is the trial. So this is a CalGB 30610 trial, which has randomized 70-gray QD-TRT, was not associated with superior overall survival compared to the 45-gray PID in limited stage setting, small cell lung cancer. Right? Small cell lung cancer, we hardly discuss anything, but this is a standard thing. They have used total 6 different varieties of quality of life questionnaires, and they assessed at baseline 3, 5, 7, 12, 26, and 52 weeks. That's when you expect the short-term, midterm, and long-term complications to happen. So once the assessment is done, they try to analyze the results. 417 patients consented to participate, but at the end of the study, they had the data for 340 patients only, and remaining for dropouts for various reasons. If you look at the baseline characters, they're well balanced. If you look at the FAT-L total score, it shows that it was significantly less in the QD arm. That means it is not that well tolerated. If you look at the FAT-L physical well-being, social well-being, and the emotional well-being, in all the arms, the QD arm fared inferiorly compared to the other arm. Similarly, functional well-being, the FAT-L score, FAT-G score, and additional concern score also favored the short-term arm. So what does it mean? It means the FAT-L TOI means worsening. That means less in the QD arm at week 3, greater in the QD arm at week 12. Similarly, the FAT-E also is having changes which are pretty much parallel to each other. Acute esophageal score was in VID arm, and was in QD arm at week 12. So that means there are more short-term complication in the PD arm, more long-term in the OD arm. Difficulty in swallowing, parallel to the acute esophageal score as expectedly, no difference. EQ5D, lesser worsening in the QD arm at week 3. Mean worsening of anxiety is less in the QD arm at week 5. So what does it mean? So it means both QD and PAD radiation regimens are well tolerated. So something is superior at week 3, but something is superior at week 12. So in other words, the QD arm once daily has better quality of life in the short term, but worse at week 12. So you need to really individualize whether you want to use OD dose or BD dose. OD dose was perceived to be less inconvenient compared to the BD dose because the acute period is tied over in a better way. So that's the first study. Coming to the second study, we always debate why 2, 4, 6, why not 2 and 3? Very interesting question that was answered. 2 cycles versus 3 cycles of neoadjuvant sintilimab plus platinum doublet chemotherapy in patients with resectable non-small cell lung cancer. It is called NEOSCORE study. It's a single center 2-arm phase 2 trial. So it's an immunotherapy that favors MPR rate compared to the neoadjuvant setting. So there is a data of using immunotherapy in the neoadjuvant setting. If you look at various trials which have been presented, they use atezolizumab, nivolumab, toripalimab, compared to durvalumab and other things. So all of them showed that both MPR rates and pathological CRs are superior when you add checkpoint inhibitors to the standard chemotherapy. So they also designed in a similar way. Sintilimab 200 mg day 1 along with chemotherapy, 2 cycles versus 3 cycles. Surgery was done, and if the patient received 2 cycles, they were given 2 more cycles. If the patient received 3 cycles, they were given 1 more cycle. And maintenance treatment of sintilimab till the follow-up. This is the study design. If you look at the planned sample size, it is a phase 2 study, mind you. It was 1 or 2 patients, 51 in each arm. They have been stratified as per the PDL1 score. 60 patients were targeted to be recruited, expected dropout rates of around 20%. So at the end of December 3, 2021, DSMB review showed that to terminate the trial because there is no point in doing the trial any further. So let us understand why they terminated the trial. This is a schema, larger schema, how the trial looked. The arms were well balanced. There is no difference. And if you look at 2 versus 3 cycles, no major difference. The p-value is insignificant. The authors felt that it may be narrow cycle difference, but it is not like 2 versus 4, where you expect more responses, as well as small sample size that didn't favor the p-value. But if they dissected deeply, the pathological CR rate is also not very significant. If you look at the regression, the graphs didn't show any difference between 2 cycles and 3 cycles, though 3 cycles expectedly have a slightly more regression because more number of cycles, but it didn't yield into any of these benefits. So if you look at the stage 3A, they are more in the 3 cycle arm compared to the 2 cycle arm. That's probably one of the reasons where they see more regression, right? So the authors concluded that the planned surgery didn't differ much. The side effect profile also didn't differ much. So they told that 3 cycles can be given. That's the only conclusion they could make, right? So that more cycles of neoadjuvant chemotherapy provide higher MPR rates for the patients with resectable, especially for the squamous subset. So that's a very, very small subset, very difficult to draw conclusions based upon this 51 patients data, but that was the observation nonetheless. So coming to the third study, it was pembrolizumab versus placebo in resectable early stage NSCLC. What is the difference in the subgroup related to the type of surgery, disease burden, and acute chemotherapy? So it's a large meta-analysis. The patients were randomized to pembrolizumab versus placebo, and the dual primary endpoints were DFS in the overall population and DFS in the PDL1 positive score of more than 50%. The secondary endpoints were DFS in any PDL1 expression, OS in any PDL1 expression, and lung cancer specific survival and safety. If you look at the overall population, they are well balanced between pembro and placebo arm. So as the PDL1 with TPS more than 50%. There are no major differences, including the EGFR expression, ALK translocation, and whatnot. If you look at the data, at the end of the 18 months, DFS in the overall population, the pembrolizumab arm is much better. 73.4% of the people have disease-free at 18 months compared to 64.3%. If you look at the median overall survival also, it is 53 months versus 42 months. So DFS is definitely superior. For those with PDL1 more than 50% score, the hazard ratio, the graphs were not separated that widely. But if you look at the median, which was not reached, it appears as if the pembro arm is faring better. If you look at the overall survival, pembro and PFS, pembro and placebo, no difference, and they are paralleling with each other. So there may not be any overall survival benefit. So if you further stratify these things into bilobectomy, lobectomy versus pneumonectomy, nodal status, tumor size, and the received adjuvant therapy versus not received adjuvant therapy. In the adjuvant therapy, the type of platinum, carbo, cis, or carbo and cis based, sometimes whatever is the differences, and type of adjuvant therapy, that is carbopaclitaxel versus carbovinerolibine versus gemcitabine cisplatin versus gemcitabine vinorelbine versus others. So if you look at these subsets also, they are very well balanced. There is no big difference. So if you look at which arm is doing better, pembro appears to be doing slightly better. In some of the cases where the nodal status are high, or when the tumor size is just less than 4 centimeters, and those who didn't receive adjuvant therapy, the pembro is not showing any advantage over the placebo. So these are the subsets probably where you may not consider pembro in these cases. The author concluded that together with overall efficacy and safety findings, these data support the benefit of adjuvant pembrolizumab for stage 1B, that is tumor size more than 4 centimeters. As I told you, the nodal status, they did matter. Following complete resection and if recommended as adjuvant therapy as well. So these are the recommendations. This is the last of 4 abstracts. This is called Skyscraper 2 study. It's a phase 3 randomized double-blind placebo-controlled study of atezolizumab carboplatin etoposide with or without adding tiragolumab in patients who are untreated with extensive stage small cell lung cancer. Mind you, this is the second small cell lung cancer in this aspect. There is a IGIT is a novel inhibitory immune checkpoint present on the immune cells in many cancer cells, including small cell lung cancer. There is a new drug which was developed targeting this, and they want to see if they add this TIGIT novel inhibitory checkpoint inhibitor will add any benefit in terms of overall survival and PFS. If you look at the study design, the tiragolumab 600 mg once in 3 weeks versus placebo when compared to atezolizumab with etoposide platinum. So the maintenance of placebo atezolizumab versus tiragolumab with atezolizumab was given. So the stratification is ECOG status, brain mets, and LDH levels. Co-primary endpoints was overall survival, and secondary endpoints were PFS, duration of response, safety, and efficacy. So this is the study design. If you look at the arms, they are well balanced. There is no major difference between the race, the tobacco use, baseline ECOG status, LDH levels, brain metastasis. If you look at the arms, surprisingly, tiragolumab has fared inferiorly compared to placebo. That means it has actually produced more harm than good. The interim overall survival also, it is showing inferior survival. 13.6 months versus 13.6 months is the median. But if you look at the graphs, the graph of tiragolumab is dipping compared to the placebo. So the PFS-OF interim analysis also showed there is no difference. And they tried to subsect based upon the preconceived stratification points. That's also showing no advantage of adding tiragolumab. In fact, the placebo arm is doing better. In various subgroups with brain metastasis, this arm is again, there is no difference. So the objective response also no major difference between tiragolumab and these things, because complete responses are, though appears to be 4% superior, but the stable disease is almost better in the placebo arm. We don't look into the response rates. We always look into the adverse event rates and the overall survivals. If you look at the adverse event profile, so they are also quite balanced, and AEs of specific interest are slightly more in tiragolumab because you have added 2 immunotherapy agents, right? The serious adverse events are also more there. So they all just concluded that the addition of tiragolumab didn't add any survival advantage. So these are the 4 things: 2 in the small cell lung cancer, 2 in the non-small cell lung cancer. The small cell lung cancer showed that probably once daily is having a slightly better tolerability, though it is having a long-term and mid-term poor quality of life, but it is still feasible to do OD versus BD in terms of fractionation in the radiotherapy. The second in the small cell lung cancer is addition of the TYK2 inhibitor didn't prolong the survival as expected. It is a negative study. These are in the small cell lung cancer. In the non-small cell lung cancer, irrespective of the subset analysis, atezolizumab has prolonged the survival in the patients, especially if the size is more than 4 centimeters. That's the conclusion of the subset analysis of those studies. So this is what it is from my side, and over to the organizers.
Thank you, Dr. Suresh, for a very nice presentation. So what do you think, which of these studies are going to be practice changing from now on or probably in times to come?
So definitely regarding the small cell lung cancer, radiation oncologists are the best people. I'm not a radiation oncologist, but when I went through these studies, it appeared as if you want a short-term comfort, use OD dose. And if you want a long-term comfort, probably use the BD dose. So I didn't see any major difference. It is more of individualization. That's one point. Point number 2 is the new receptors in the small cell lung cancers appear to be elusive because the new receptor also didn't produce any benefit in the phase 3, it failed. So small cell appears to be status quo, no major change. But yes, definitely in the non-small cell, adjuvant atezolizumab may come into the picture. That's what actually is the positive side of the picture that I see in these cases.
Right, I agree. Thank you so much for a very nice presentation. So we are going to discuss more of this in the panel discussion that ensues. So with this, we come to the next part of our meeting, and which is going to be a panel discussion, which is going to be moderated by Dr. Chaturbuj. Dr. Chaturbuj, sir, good evening.
Hi, Dr. Rajat. Good evening. Am I audible?
Medical oncologist at
Yeah, Rajat, am I audible?
Yes, sir. You are. Yes.
The updates in ASCO 2022 in lung cancer, and how does it really change our practice? Sir, please, can you call your moderators? Sorry, call your panelists.
My moderator, you are my moderator, Rajat. So, because you are moderating everyone, so you are the moderator. And panelist, I think everybody has joined. Dr. Mansi Sharma, I can see her. Dr. Mansi, good evening. Dr. Sunil is there. Dr. Kripa, I think she has not joined. And the other 2 panelists, Dr. I think just
Dr. Rakesh Pinati and Pinaki.
yeah, Dr. Rakesh Pinati and Dr.
Pinaki Mahati.
Yeah, so both of them have joined. Are you there, sir?
Yeah, I'm here. Pinaki.
Yes,
sir.
Dr.
Good evening.
Pinaki.
I'm here.
Yeah, Dr.
Rakesh.
Pinaki. Yes. So, thank you. So, just a minute. Can you? So, let's start the panel discussion. We are already late. So, Dr. Pinaki and Dr. Rakesh. Okay, fine. So let's start the panel discussion, and I have kept these slides very simple, and I kept two cases, basically one non-small cell lung cancer and one small cell lung cancer. And I think somebody can correct me if I am wrong in this presentation, because I prepared these slides on my own. So let's start with the presentation. Yeah. So the snail pace of lung carcinoma chemotherapy was this is my favorite slide. Professor Kennedy, he first recognized that advanced lung cancer could respond to chemotherapy, and it was first presented in 1948. And I think most of us, we are from the same era of means this era where we were learning about the role of chemotherapy in metastatic setting, and then we started learning the role of chemotherapy in adjuvant setting of non-small cell lung cancer. And when we all started our practice, we saw all of this discussion coming up, like initially EGFR directed therapies, and then PDL1 therapies. So adjuvant chemotherapies improve survival. This is the old slide. And when we started, I think when we started our residency, we were aware of only this data. So that used to be the time when this used to be the most favorite slide for examiners, and they keep on asking us what is the role of adjuvant chemotherapy, in which setting you will give chemotherapy, which chemotherapy you will give, and ANITA trial, adjuvant lung trial. So all those things were our favorite trials. But now coming to ESCO 2022, after this ESCO 2022, there is one common question. So after all of this, lot of presentation, we came to this question, which I find that is adjuvant or neoadjuvant chemotherapy enough, or we are means it's not enough. So before I move on, I want to make a submission that we keep on discussing so much of data, so much of new things, but we always tend to means forget one thing, that these drugs are practically not available. Means to be very honest, I will start with myself. I have not used these drugs in adjuvant or neoadjuvant setting till now, although I've used these drugs in small cell and non-small cell in metastatic setting, but not in neoadjuvant and adjuvant setting. So I would like to know from you all before I start this presentation. So I think Dr. Mansi, she has the most enormous experience with Rajiv Gandhi. So Dr. Mansi, in which of the following settings you have clinical experience with these drugs? Can you please enumerate?
Yeah, well, we use them. I mean, we've used it as a single agent in both, in NSCLC metastatic setting. SCLC, we've started giving atezolizumab. We mostly use atezolizumab in combination in extensive stage. We've given it to around, I think, 6 patients, I think. So we will hopefully try to collate the data maybe by next year. And we did have a neoadjuvant trial running in Rajiv Gandhi, the Asian trial. So we had around 3-4 patients on that. So we gave neoadjuvant durvalumab along with chemotherapy in that. So I do have some experience, and well, affordability is always an issue, but for whoever who can afford, yes, we're giving.
Excellent. So I was expecting from you that you must have used it in across all the setting, and that's true. Dr. Pinaki, can you tell me about your experience? Means you can also add on that whether you have used in only metastatic setting, or means we will be glad to hear if you have used in a neoadjuvant or adjuvant setting.
Only in the metastatic setting. I have started discussing with the patient.
So, sir, I have.
Yeah, but only in the metastatic setting I have used, not in the neoadjuvant adjuvant still, but I have started discussing with the patients the pros and cons of using in the neoadjuvant setting.
Yeah. Dr. Rakesh?
Sorry, never in the neoadjuvant or adjuvant setting, sir, only in the metastatic setting.
But across both NSCLC and SCLC, you have used in metastatic setting.
Both NSCLC, SCLC in the metastatic setting, but never in the adjuvant or neoadjuvant settings.
Okay. And Dr. Sunil, sir?
So I have used in metastatic setting NSCLC as well as extensive small cell, and have used atezolizumab as adjuvant in 2 patients till now. So
Excellent.
they are undergoing, they are on adjuvant atezolizumab.
Excellent. So personally, I have not used in neoadjuvant or adjuvant setting. I have also used only in metastatic setting, and that too more in non-small cell lung cancer rather than small cell lung cancer. So without wasting time, let's quickly go on to case 1. So I kept this case very simple for discussion. Mr. X was a 35-year-old gentleman who was complaining of breathlessness and chest pain, and he had a significant smoking history, and he went to a general physician where he underwent CT scan, head and chest and brain, and he was found to have a right apical segment mass 3.5 by 5 centimeter. There was no significant lymphadenopathy. A biopsy was done from that mass and it was suggestive of non-small cell lung cancer adenocarcinoma. So now this patient is being referred to medical oncologist. So Dr. Sunil, can you tell me how will you approach this case?
So for this patient who has a like a 5 centimeter lesion on scan, first I would like to go ahead with a PET CACT for this patient to look for the staging of the patient as well as mediastinal node. If mediastinal nodes on PET scan looks metastatic, then we'll proceed with mediastinal staging with the available technique, whether it is a mediastinoscopy or IBUS. And then if turns out to be early breast cancer, then definitely we'll consider for surgical things. Depending on the stages, then we will think. And if it's an early stage, definitely I will consider MRI brain to rule out brain metastasis.
And if it's an advanced stage, then you will not do MRI brain?
Then definitely we'll do, but proceeding
you
to
said
surgery,
if it's early stage.
I mean to say before proceeding to surgery, we'll have a MRI brain scan.
So you will do is there any subset of patient in which you will avoid doing a MRI brain?
So usually in metastatic setting with non-small cell lung cancer without symptoms of brain mets, I don't do MRI scan.
So in metastatic lung cancer, you will not do, but if it's an early stage lung cancer, you will do MRI brain. So
Yes,
up to
yes.
which stage you will do? Let's say if it's a 2 by 2 centimeter lesion.
Maybe I tend to do MRI brain before proceeding to surgery.
Okay, okay. Any difference of opinion? So Dr. Rakesh, any difference of opinion?
Sir, I would do MRI brain for all patients of lung cancer, irrespective of the staging. More so for those patients who are going for surgeries. Yes, PET scan in all cases, I'll probably do it. And if the patient already had a CT chest and thorax, probably I would avoid doing a PET CT. But if I am the person who is doing the staging evaluation, probably PET CT and MRI in order. Molecular testing in the early stage, I'll do a focused testing of EGFR alone, not an extended panel. This is how I do, sir.
Great, great. Dr. Mansi, you also agree with Dr. Rakesh or you don't agree?
Yeah. I mean, agreed, absolutely. Molecular staging. So definitely EGFR may be extended NGS depending on whether we have a trial coming up or not in the neoadjuvant setting. So basically that. Otherwise, in routine clinical practice, not right now, not till we have more data.
So I think means most of us agree, and means when I went back to check NCCN, because once we finish our academics, we of very less often we see NCCN guidelines and we practice what we feel. So means most of us are correct. Means if somebody doesn't do MRI brain, means I mean he's not wrong. But as far as NCCN is concerned, any patient from stage 2 onwards, we are supposed to do PET scan in all the cases if not done previously, and MRI brain with contrast from stage 2A onward. Stage 2 and stage 3A onward we should be doing. Stage 1B it's optional. So I think this was already told by Dr. Sunil. So it's perfectly fine. Means for a very early stage, he said that he would like to do MRI brain for even stage 1, but it's optional. So I think it's either way it's correct. So how do you decide resectability in your clinical practice, Dr. Pinaki? Is there any means I'm sure you will say that you send it to surgeon and they decide, but is there any criteria in your clinical practice? Because
no, actually, I
my
let my
experience is bad,
oncosurgeon
because
decide.
when we send to surgeon, he always feel that it is resectable.
No, it's the other way around. Actually, we have in the lung, basically you have to see whether what extent of the lung has to be resected. So generally with the central tumors and all, it is definitely more of a pneumonectomy rather than a segmental resection. So it is generally at the discretion of the oncosurgeon and let them decide what is resectable and what is not.
Okay. Dr. Rakesh, what is...
I think it's a shared decision between pulmonologists and surgeons most of the times. Medical oncologists usually take a backseat in these. I would say there is an additional factor of waiting list for surgery as well in busy centers. That can also play a factor, irrespective of resectability or not resectability. There it could be a factor for a systemic treatment in that setting as well. But it is most of the times a pulmonologist and surgeon who take the call. We usually take a backseat.
Yeah, agreed. But why I put up this question is because now, we have, we in fact, throughout today's complete discussion, we were discussing about role of neoadjuvant immunotherapy coming up. So when we refer to the surgeon, means most of the time the patient means land up doing surgery upfront. But when we decide that this patient fits for neoadjuvant, so means we need to discuss. But differentiating between a resectable and unresectable status is means it varies from surgeon to surgeon. And resectable means obviously there are certain diseases like matted N2, matted N3, bulky N2. These are all obvious unresectable disease. But resectability status often change even after when somebody plans for definitive chemoradiation, and there is no universally accepted definition of unresectable stage 3 disease. So determination is usually made on a case-to-case basis. So Dr. Mansi, has this happened in your clinical practice that you have decided for a definitive chemoradiation, and after definitive chemoradiation the surgeon feels that now the patient is resectable and means you are sending from surgery?
It happens occasionally. I mean, it happens occasionally. I mean, tumor board yesterday, we had a patient who's EGFR mutant, post multiple lines, osimertinib, doing very well. Finally has a very small lesion. So, we do take these cases up where they've had a very good DFS to see whether we can or not, but it's very rare. And we obviously decide these things in tumor board. So,
okay. So these are all exceptional scenarios, but as a rule of thumb, once we decide that it's a definitive chemoradiation, then after definitive chemoradiation, we don't operate, right?
now, unless, again, the patient is doing very well for a long time with, a very small burden of disease, but those are exceptions rather than the.
Okay. So Dr. Sunil, again, which neoadjuvant chemo regimen, suppose this patient surgeon send back to you and says, better you give some neoadjuvant chemotherapy and then I will operate. So which neoadjuvant chemo regimen you will choose? What is the role of PD-L1 inhibitor? I think we can take all these three questions.
Yeah, so if the patient is fit, my choice of neoadjuvant regimens for adeno remains pemtrexid and cisplatinum. So PEMCIS for 4 cycles is what I use. Role of PD-L1 inhibitors. So as of now, I have not used in neoadjuvant setting, but based on the recent checkmate 816, I am trying to communicate to patient regarding the role of neoadjuvant immunotherapy and trying to convince the same, though we don't have approval for same.
Okay. And what are the number of neoadjuvant cycles? Okay, so you already mentioned 4 cycles.
So 4 cycles.
Dr. Pinaki, can you differ, or is there any difference of opinion from Dr. Sunil?
No, sir. I think we are more or less on the same page. Whether to give 3 cycles or 4 cycles, I think the opinion might vary depending upon the biology. It is squamous or not squamous. We decide the pemetrexed versus nab-paclitaxel. But now we have seen in the data that there is a PCR rate of almost 25 to 35% in the checkmate and the Nadim trial. So definitely very, very hopeful that patients would agree to take the PD-L1 inhibitor with neoadjuvant. And I think in that setting, it is 3 cycles of chemo plus.
Is there any downside of using PD-L1 inhibitor? Let's say patient is completely affording, he says means money is no constraint and PD-L1 is by TPS more than 50% and the patient is absolutely fit and fine, no autoimmune disorders. So means
I think they have recommended that you should not use PD-L1 then in the adjuvant setting. That is one thing that I saw.
No, in neoadjuvant. Is there any downside of using?
You are not supposed to use in the adjuvant, something like that.
Okay. Is there any downside, Dr. Rakesh? Do you feel that there is some downside of using a PD-L1 inhibitor in the neoadjuvant setting?
I'm not sure because there is no data forthcoming saying that surgical outcomes are bad or surgical delays are going to progress the patient. But I think the 2 cycles of nivolumab previously was one study that showed a major pathological complete responses, pathological responses. And now the phase 2 Nadim and the Checkmate 816 are showing a better pathological complete responses, but we are still skeptical about how much it is going to translate into survival. So I'm not going to push for it, but it's an option for those patients who can afford for it. I don't think so there will be any major downtrends.
Yeah, I think somebody can correct me if I'm wrong, but I read it that if we use PDL1 inhibitor, the surgical colleagues, they may have more problem in operating, and there were more rates of thoracotomy after using PDL1 inhibitor in the neoadjuvant setting as compared to only chemotherapy, and majority of the patients, they landed up with thoracotomy. So this is something which is the downside. And the positive side, we have already seen Checkmate 816 neoadjuvant nivolumab plus chemotherapy. It has shown significant improvement. And if you see the PCR rate, so this was the Checkmate 816, which I think Dr. Pinaki was telling. So in Checkmate 816, pathological complete response were seen in majority of the patients, and this pathological complete response means, like in breast cancer, we've seen pathological complete response turning out to into overall survival. So this was seen in this Checkmate 816, but it's too early, as was said by most of the panelists, and we need to learn more from these points. But this is a very good evolving data. Similarly, Nadim 2 was shown by in his presentation by Dr. Rishabh Kothari. So he presented this trial in detail, and he has shown that this in Nadim 2, nivolumab plus paclitaxel was used for 3 cycles, followed by surgery, followed by only adjuvant nivolumab, and then follow-up. And this trial has also shown very good response rate with neoadjuvant nivolumab with chemotherapy. Similarly, we have the role of neoadjuvant atezolizumab, although this is a phase 2 trial, but when on the 39 patients, they were assessed for eligibility, out of which 30 patients, they received neoadjuvant atezolizumab, and 26 patients, they underwent successful R0 resection. So I think these are all the data which came up, and this is the neoadjuvant immunochemotherapy clinical trial data which is going on. And the last speaker, Dr. Suresh sir, I think he presented the data of 2 cycles versus 3 cycles of neoadjuvant nivolumab with chemotherapy, and that ASCO 2022 has already shown that 3 cycles were found better than 2 cycles of nivolumab plus chemotherapy. So these are all our new drugs: toripalimab, nivolumab, atezolizumab, platinum doublets, followed by durvalumab, and also AstraZeneca is extensively investigating durvalumab in the neoadjuvant setting after its phenomenal success in the adjuvant setting in Pacific trial. So more and more neoadjuvant immunotherapy data is coming up. So this patient underwent surgery finally. So this patient didn't receive any neoadjuvant therapy. The surgeon changed his mind and he did surgery. Final histopathology was adenocarcinoma T3N0. All EGFR, all cross-mat was negative. PDL1 was 60%. So Dr. Mansi, which factors, what next you will do? This patient comes to you after surgery. So what factors you consider, means before giving for adjuvant chemotherapy, or this, what will you do with this patient?
No, hang on. He received NSCT.
No, he didn't receive NSCT. Surgeon changed his mind. He said he can operate. He operated and it was finally T3N0.
Okay, all right. Okay. So he's molecularly negative. Okay.
Yeah, adenocarcinoma T3N0 post surgery.
So your question to me is specifically regard to adjuvant immunotherapy or adjuvant
No,
treatment?
I am just asking what adjuvant therapy will you give? This patient comes to you for further treatment.
So chemo, yes. Immuno. What was the PDL1 positivity? I'm sorry.
50%. PDL1 was TPS was 60%.
Okay. So not sure about immuno.
Not sure about immuno. Doctor, any difference of opinion, Dr. Rakesh?
Yes, sir, surely for cisplatin combination chemotherapy for this person, and he would receive 4 cycles of chemotherapy and followed by immunotherapy because there is data to suggest and back up the PFS.
Okay, so how many cycles of immunotherapy and which immunotherapy you will prefer?
I personally haven't used it in any patient. Probably I will use atezolizumab. I would go by the clinical trial study design. Atezolizumab probably after chemotherapy, and I'm not sure about number of cycles. Sorry.
Yeah, sure.
It is 1 year of atezolizumab, I think.
1 year of atezolizumab. Okay, and Dr. Sunil, You also.
Yes, I agree with Rakesh sir. Chemotherapy definitely yes for 4 cycles, and in view of PDL1 positivity, atezolizumab as a adjuvant maintenance for 1 year after chemotherapy.
So no other choice apart from atezolizumab after ESCO 2022?
No, still my preference will be atezolizumab.
Sure, perfectly fine. So which factors we do means my question, my intent of asking this question was whether we do consider type of surgery when we choose our adjuvant chemo regimen, whether we consider strength of PDL1 positivity, and whether we see whether patient has received adjuvant chemotherapy or not when we want to decide on adjuvant immunotherapy. So IM power 010, which most of our panelists they were means I think referring to atezolizumab for 1 year. So this atezolizumab has already shown statistically meaningful DFS difference in from stage 1B to 3A onward when given after chemotherapy. But what I wanted to emphasize is from atezolizumab was given only to those patients who had PDL1 more than 1%. But after ESCO 2022, this is one of the data which was presented by the previous speaker, Keynote 091. So in this patient population, they stratified the patient population into two types, means TPS more than 50% and less than 50%. And DFS benefit was generally consistent across most of the subgroups. So whether they are PDL1 positive or PDL1 negative. So pembrolizumab it improved DFS regardless of surgical resection, regardless of whatever type of surgery done, regardless of degree of lymph node involvement, regardless of tumor size, and regardless of type and extent of chemotherapy. So together with this thing, means this data has come up, this checkmate data has come up that pembrolizumab can be given to this patient for up to 18 cycles. So this is something, how long to continue? I think we answered this question. Other markers, I just kept this slide to for a revision. So this patient, scenario 2, so Dr. Sunil, this patient underwent surgery and final histopathology is again adenocarcinoma, but this was EGFR del 19 positive. Sorry for the typing error. Del 19 positive, PDL1 is 1%. So what will be your adjuvant treatment of choice in this case?
So for this patient, adjuvant chemotherapy definitely I will give, and as he is a EGFR positive, then osimertinib for 3 years as an adjuvant if patient is affordable.
So, okay, ADORA trial, we all are aware of ADORA trial. This is the old trial. This was presented in ASCO 2020 and the updated analysis, I think, was presented in 2021. But it was basically osimertinib 80 mg once daily for 3 years versus no treatment. And there was a significant DFS benefit. We all are aware of this. So these are ongoing randomized phase 3 clinical trial of adjuvant EGFR TKI. So we have seen neoadjuvant immunotherapy, adjuvant immunotherapy trials, and these are adjuvant EGFR TKI therapy. Adjuvant TKI therapy. I think Dr. Mansi is also the investigator of one or two of these trials. I think ADORA was there. So these are the trials which are ongoing for EGFR TKI. So this is again from NCCN. Whether when patient comes to us for adjuvant therapy, now this as per guidelines we have to give chemotherapy plus atezolizumab or osimertinib if EGFR positive, or chemotherapy plus atezolizumab, chemotherapy plus atezolizumab. Pembrolizumab is still not in the guidelines. Atezolizumab, because IM power trial it came first. So atezolizumab is there in NCCN guidelines. So even if the patient has received preoperative chemoradiation and underwent surgery, chemotherapy plus atezolizumab is the standard of care. And most of our panelists, they also, I think, are more familiar with atezolizumab. However, if the patient has underwent definitive chemoradiation, then everywhere it's durvalumab and there is no role of atezolizumab. So lessons learned, I tried to keep only 5 points simple, which I learned from after ESCO 2022. Role of NGS in early stage NSCLC is evolving, and as far as possible, all early stage patients should undergo broad spectrum NGS for all molecular markers. Only neoadjuvant chemo is not enough, and coming decade may change the entire armamentarium by introducing PDL1 therapy in the neoadjuvant setting, because we have seen in the nivolumab trial how much statistically significant PCR difference can make. Only adjuvant chemotherapy is not sufficient now for most patients, and most patients they require chemotherapy followed by either EGFR directed therapy or immunotherapy. So patients who receive definitive chemoradiation are candidates for durvalumab, and patients who underwent surgical resection and received adjuvant chemotherapy are candidates for either adjuvant osimertinib or adjuvant atezolizumab. So quickly, I will just go through in the interest of time. Case 2, I have to finish small cell lung cancer also. So 74-year-old male, he was a retired government servant, a heavy smoker. He presented with dyspnea and cough. He was ECOG PS2 at presentation, and on chest X-ray there was a right upper lobe mass. He underwent CT scan. It was again showing a right upper lobe mass with mediastinal and hilar lymphadenopathy and multiple bone and liver lesions. And MRI brain was done. There was no metastatic disease. So he underwent a biopsy and IHC, and biopsy was suggestive of extensive stage small cell lung cancer because he had multiple bony and liver lesions. So, Dr. Sunil, what will be your treatment option? Means what would be your choice? I know means all of the options which I mentioned are means probably
But
all of them are correct.
for this patient, I would like to use atezolizumab plus itopo carbo chemotherapy for 4 cycles and then followed by maintenance atezolizumab.
And you won't prefer durvalumab plus
This
etoposide
patient
carbo?
has no brain mets at baseline, so preferably when I use durvalumab whenever patient has a brain metastasis at baseline.
Okay, I hope
And also the
AstraZeneca people are not
number
listening
of
to you.
yes.
So, Dr. Mansi, what is your treatment of choice?
Elderly gentleman, PS is borderline. I would actually, either give single agent carboplatin initially, wait for him to recover, or give him just a small dose of etocarb first, wait for him to recover, and then definitely add immunotherapy later on. I mean, definitely.
Excellent.
So either, but cisplatin I don't think is an option. 71 years old, I don't think his creat clearance would be very good. And either atezo or durvalumab.
Exactly. So, Dr. Rakesh and Dr. Pinaki, please one by
I
one.
would go with etoposide carboplatin with atezolizumab followed by atezolizumab maintenance. And that would be the primary because of more experience with atezolizumab, and probably you will not be using carboplatin, cisplatin for this patient. And he has no brain mets, so there is no issue of whether the patient is being trial selective or not. But I think atezolizumab has more data. We are more comfortable.
Dr. Pinaki, you will
I
also
agree.
prefer atezolizumab?
I just want to make one point. Actually, we all discussed that in brain metastasis, durvalumab works and atezolizumab doesn't. But if you look at the Caspian trial, the hazard ratio is all over the place for brain mets. It's 0.3 to 1.3. So I am not sure that in brain mets durva will work and ato will not. In this case, definitely without brain mets, atezolizumab would be my.
That is just by virtue of this that in Caspian they included the patient.
And the Caspian trial included only those patients who had.
Yeah, please go ahead.
So the point I was making is at least there was an option of having a asymptomatic brain metastasis, or those symptomatic brain metastasis were radiation treated and subsequently are stable in the Caspian trial. But I think the atezolizumab clinical trial has completely excluded those sort of patients. So based upon the presence of brain metastasis, patient can go ahead with radiation, can get on with immunotherapy with durvalumab, but that's not a choice with atezolizumab.
Yeah, but I think that was that is perfectly well taken. But the previous, yeah, but what he was trying to tell is also correct, that the means by virtue of just inclusion of patients who had brain mets, we cannot say that durvalumab works and atezolizumab doesn't work. So I mean, I also agree with him. So role of immunotherapy in SCLC we know. I think we can skip this slide. So atezolizumab plus cisplatin or carboplatin is the standard of care, and most of the patients, if we give them first line, don't give them in the first line, the typical progress within 0.5 to 6 months, and their life expectancy is less than 1 year. So Caspian is the trial which has approved IO regimen in the extended stage SCLC, and I think what I wanted to show you is the difference. Which one to choose, that is atezolizumab or durvalumab? So we were discussing about this thing. So what is the difference? The Caspian trial allowed both carboplatin and cisplatin, while in IM Power only carboplatin was allowed. In Caspian, I think patients with symptomatic and asymptomatic brain mets with radiation therapy is recommended before or after systemic therapy, while patients with brain metastasis were only eligible if they have received prior treatment in IM Power. So only controlled brain metastasis were included. And here both 4 to 6 cycles of PP were allowed. So I personally feel that the control arm in Caspian was more robust as compared to IM Power, because in IM Power only 4 cycles of PP were allowed. So personally speaking, I feel that durvalumab trial was more strong because of the more robust comparator arm as compared to atezolizumab. But by saying this, I doesn't at all mean that we can make this cross trial comparison. Obviously, we should not do that. And if somebody has more experience with atezolizumab, I think it's perfectly fine to use atezolizumab. So this is the Caspian versus IM power head-to-head comparison. Median OS difference is, I find both of them same. Only thing in IM power, only the brain metastasis were controlled, they were included, and in Caspian, the uncontrolled brain metastasis, untreated brain metastasis were also included. So these are the guidelines we all know. So in the interest of time, I will not take much time and I will quickly come to the conclusion. So durvalumab plus EP is the standard of care, or atezolizumab plus platinum-based doublet is the standard of care. And whenever possible, we should try to give first-line IO agent with chemotherapy. Although, but I agree with Dr. Mansi that the patient was PS2, so better to give some induction regimen first and make fit to receive this therapy. And I think we all know these points. So one important point just I wanted to highlight, because I learned it for the first time, so I wanted to highlight it, that in Caspian, the IO agent, the administration schedule is very much different. And in induction, it was given 3 weekly for 4 cycles, but in maintenance, it was given every 4 weekly. This for durvalumab. In fact, for nivolumab trial in the neoadjuvant setting, the dose was 360 mg every 3 weekly. So I find a lot of differences in dose of IO agents, which means which we need to keep in mind whenever we plan some neoadjuvant or adjuvant therapy, because the doses and schedule are very much different. So with this, I thank all my panelists, and in the interest of time, I presented it. I completed it. Thank you. And over to Dr. Rajat.
Thank you, sir. Thank you for a very nice moderation of the discussion on lung cancer. Both the NSCLC and the SCLC part was covered. I thank all the panelists for their very active participation. With this, we come to the end of this oncology updates, this 2-day updates we had. The first day we talked about breast and ovarian cancer, and the second day we've spoken about lung cancer. We've spoken about the role of comprehensive NGS in lung cancer. We've spoken about the very much talked about neoadjuvant immunotherapy in lung cancer. In fact, this particular topic has been spoken in 3 sessions now, including the last panel discussion. We've also spoken about the role of atezolizumab in the first line NSCLC, and a few things which we have learned when we've spoken about the ASCO 2022 updates. I thank everyone for being a part of this discussion over the last 2 days. I thank our academic partners for their sponsorship. And I thank the faculties for sparing their time for being a part of this discussion. Last and not the least, I thank people at Horizons for helping us taking us through this particular updates. So I would now like to say bye bye to all of you, and have a great evening ahead. Till we meet again, thank you very much.
Thank you so much, Dr. Rajat, for giving this opportunity. Thanks, everyone, on behalf of my colleagues, Geetika and Pooja. Thanks once again. Stay safe, stay blessed. Good night from all of us.
Thank you. Bye-bye.